All right, class is in session. So again, chat box is open if anybody needs to throw a chat up to the whole group or to me personally, and I can answer your questions that way. All right, so tonight we're going to cover cardiovascular emergencies, and then we're going to cover toxicology after that. Once those two are done, we'll be done for the night. And then the quiz will post at 10 p.m. So after 10 p.m., you will have until Sunday at 9 a.m. to complete the quiz that's on there. All right, so we're going to cover a little bit about pathophysiology, which applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. So really important for us to understand how the blood gets through the body and also how it oxygenates for the cardiovascular system to function. We're going to cover the medicine behind it as well, which applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. We're going to go over anatomy, signs and symptoms, and the management of chest pain and cardiac arrest. Anatomy, physiology, and pathophysiology assessment, and management of the acute coronary syndrome, what they call ACS, for angina pectoris and myocardial infarction. So the chest pain and the actual heart attack. And we're also going to cover aortic aneurysms and aortic dissections. We're going to cover thrombolism, heart failure, hypertensive emergencies as well. So the cardiovascular disease has been the leading killer of Americans since 1900 and accounts for one of every 3 deaths. We see this a lot. We see this a lot in the field, cardiovascular emergencies, whether it be acute coronary syndrome causing chest pain. We've seen just literally the other day, I had a medical call where a patient was in congestive heart failure, had some left-sided failure going on with fluid buildup in the lungs. We had to use CPAP to reduce the fluid in there, and we couldn't go with nitrates because obviously the patient was very hypotensive of a blood pressure in the 80s. And literally just last night, I had to do a paramedic intercept one of our crews because we had a patient who had multiple syncopal episodes, so passing out. Come to find out his heart rate was 32. So electrical conduction issue. He's probably going to be going for a pacer. We actually got flown this morning to Connecticut, to Hartford emergency room, which was the closest available ER to take this guy for a cardiovascular issue. So they're out there. We get a lot of calls for this as well. So EMS can definitely help reduce deaths by encouraging healthy lifestyles, early access to medical care, more CPR training of the lay people, and obviously increased use of involving technology in dispatch and cardiac arrest response. So what they're saying here, obviously, is public relations stuff. So one of the biggest healthy lifestyle encouragement and also providing the CPR training is what they call heart safe community. Maine has it, New Hampshire has it, Vermont has it, Massachusetts has it. All of our New England states have what they call a heart safe community project. And what this does is it helps become heart conscientious with the town itself to help get out information about how to be healthy, how to prevent diabetes from happening. If you do have diabetes, how to keep it under control. It also puts out the hands-only CPR. And American Medical Response, AMR, does a national initiative. They have one day a year where they have like a national CPR day where they try to see which state or which region gets the most people through hands-only CPR. And you don't have to be a CPR instructor to teach that. So that's the part about more CPR training to lay people. Early access to medical care, obviously early recognition, and then also calling 911 and getting early advanced life support on scene as well. And also with the increased use of evolving technology with dispatch, and that's emergency medical dispatching with the ability to give people CPR instructions over the phone and dispatch the appropriate personnel to the scene. So there's a lot of stuff that can happen with EMS that can help reduce death. Public access to defibrillation devices, so that's also part of the Heart Safe initiative as well, putting AEDs in public buildings. recognizing the need for advanced life support. When you guys get on scene, is this a sick or a not sick patient? We're looking at our general impression. Does a patient need advanced life support? The use of cardiac specialty centers when they are available. And what they're talking about for the centers is going to be like a PCI center. Ooh, my apologies on that. All right. There we go. So, anatomy and physiology. So, obviously, the heart's job is to pump blood to supply oxygen-rich blood cells to the tissues. And they are divided into the right and left sides. So, obviously, we take a breath in, oxygen comes in. Remember, it goes into the lungs. It's picked up as the blood is passing through from the right ventricle, going into the left atrium. So it's picking up blood through the lungs, through the alveoli. So oxygen comes in, blood goes through, it's picked up and delivered through the left ventricle and pumped out to the body, through the arteries, to the arterioles, to the capillary beds where more gas exchange is happening. Then as it's coming through, it comes back through the venules into the veins. Now remember, blood is pumped through that way through valve systems. So remember, arteries are under pressure, veins are not. So they have to build their own pressure to get through because the capillary bed slows that down so much. So what's happening is blood is pumping through the venules into the veins. In the veins, there's valve systems built up through it. So when it builds up enough pressure, the valves release and it pushes the blood through. Obviously, it's still a continuous flow. That's why when you have a venous bleed, it kind of oozes out versus an arterial bleed, which actually squirts out in spurts, because that's what you're seeing with that. So we got to make sure that we have oxygen coming in, it attaches to the hemoglobin. The hemoglobin then acts as a transport system to get it to the cellular level to help get oxygen-rich blood to the tissues. If we don't have that happening, we start going into shock, which is the inadequate state of tissue perfusion. As you can see here, looking at the anatomy physiology of the heart. All right, so there are one-way valves that keep blood flowing in proper direction. All right, so in the heart, we have 4 different valves. All right, we have the tricuspid valve, the pulmonary or pulmonic valve, we have the mitral valve, and then we have the aortic valve. One way to remember that is TPMA. Now, again, we're all adults. So one of the things that helped me remember this through school, and I learned this back in EMT school in 1999, was toilet paper my ass. So TPMA, 4 letters, 4 valves, tricuspid, mitral, or tricuspid, pulmonic, mitral, and the aortic valve. So again, in EMS, sometimes remember dirty things like that to remember certain acronyms. So again, we have to have valves that move forward that they can't backflow back in. Now, we'll get into heart failure a little bit later and how things backflow. The aorta is the body's main artery. That's your main supply coming in. Receives blood ejected from the left ventricle. So think of your, for the firefighters in the room, think of your aorta as a large diameter hose. Your 6-inch line, your 5-inch supply line. Right? That's where all the blood is coming through. That's your supply line. If you lose your supply line, what happens to the pump? It cavitates and it fails. You run out of water. Firefighters die in a building. Same thing that happens in the body itself. If you lose your major supply line, you bleed out, and you bleed out quickly. One way to think of your aorta as well, as far as size-wise, is about the same diameter as a quarter. So if you think about that going through your body, imagine that rupturing inside. It wouldn't take more than 90 seconds to completely bleed out. So the superior vena cava has oxygen poor blood from the head and upper body. The inferior vena cava takes the oxygen poor blood from the lower body. As it comes in, it goes in through the right atrium. It passes through into the right ventricle, going through the first valve, going into the right ventricle, and then it passes through the left pulmonary artery, which is putting blood into the lung. Okay, blood is flowing through the lung. As it's coming through, it passes into the left ventricle, left atria, then goes into the left ventricle as oxygen-rich blood. It pumps out through the entire body, as you can see looking at the picture on the right-hand side. So as it's coming through, and then it comes back through the veins, as a deoxygenated blood comes back through the system, and then it picks up oxygenated blood after going through the atria and the ventricle, going on the right side, going back into the lungs, pick up your oxygen-rich blood again as the patient is taking inspiration and expiration. So keep in mind that there's two ways of reducing or producing the gases. So one, obviously, would be through your removing waste through your lymphatic system. And then the second part of waste is coming through as carbon dioxide as you exhale. So it's taking that deoxygenated blood in a carbon dioxide form, and you're off-gassing it by breathing. The next part is the heart's electrical conduction system, which the heart's electrical system controls the heart rate and coordinates the atria and ventricles. We have to have these systems working in play in order for the heart to pump effectively. Now, there are conditions out there like atrial fibrillation, where the heart does not pump effectively, or other different rhythms out there as well, where we might see like ventricular tachycardia or ventricular fibrillation, where the heart is no longer pumping effectively at all, or VFib, where the heart is kind of quivering. So if you were to take a bowl of Jello out of the refrigerator and shake it, that is exactly what your heart is doing. It's quivering, but there's no electrical conduction happening at that point in time, or organized electrical conduction, I should say, to pump a heart effectively. So automaticity allows spontaneous contraction without a stimulus from a nervous source. So if impulses come from the SA node, which is a sinoatrial node, the other myocardial cells will contract. If no impulse arrives, the other cells are capable of creating their own impulses and stimulating a contraction. And that goes into what they call the AV node, which is your atrioventricular node. So looking at this picture here, and it's a bunch of color-coded things that probably make no sense at this point in time. So let me explain it to you. The SA node is your major, it's like the hub of electricity. The SA node runs at what they call an intrinsic rate. The intrinsic rate, and these are things you guys might want to write down, the intrinsic rate is 60 to 100 beats per minute. What's happening is it fires from the SA node, going through internodal pathways, which then goes into the AV node, which then passes through the bundle of His into the right and left bundle branch into the Purkinje Fibers. Now, if your SA node fails, like we talked about before, you have a second backup generator to help you out. That backup generator is called the AV node, which has an intrinsic rate of 40 to 60 beats per minute. If that fails, you have one backup system left in your system. Those are called the Purkinje Fibers. And the Purkinje Fibers go around the lower parts of the ventricles, as you can see looking at the picture. And those run at an intrinsic rate of 15 to 30 beats per minute. So that's like the last-ditch effort generator kicking on in your system to help keep the heart alive. And that's the electrical conduction system of how that works. So the SA node fires, and as it's firing, it's causing the atria to contract, pushing the blood through, which also allows the ventricle to contract, pushing the blood through into the lungs, into the left atria, which then contracts on electrical conduction, which then pushes the blood to the left ventricle, which pushes it out to the body. So right now, if you were to feel your pulse, if everybody's at home took a radial pulse really quick on yourself, and you feel the heartbeat, that heartbeat is your left ventricle, what they call depolarizing. So it's it's causing electrical conduction through the Purkinje fiber, causing that left ventricle to pump blood through the entire body. So every time you feel a heartbeat, whether you feel a carotid or a radial pulse or a brachial pulse or whatever one you want to use, that beat is your left ventricle depolarizing and or firing electricity to cause the big pump to pump the blood throughout the body. So with this, the autonomic nervous system, what they call ANS, controls involuntary activities. The ANS has two parts. They have a sympathetic nervous system, which is a fight or flight, and a parasympathetic nervous system, which slows various bodily functions, what they used to call the feed or breed system. Now they just call it these slow various bodily functions. The myocardium must have continuous supply of oxygen and nutrients to pump blood. Right? So if you think of the heart looking at the different layers, endocardium, myocardium, pericardium, right, the three different layers of the heart. The inner layer and the middle layer really don't have a lot of vessels that run through that. So what's happening is done through what they call osmosis, pulling the blood through, and also diffusion, pulling the gases through to get the gases in the oxygen-rich blood to the cells in the center of the heart. When you have an infarction, which is tissue death, your heart starts dying from the inside out because it's got a blockage somewhere in one of your major arteries or vessels of the heart, causing it to be blocked, therefore causing the heart to get less oxygen to where it needs to be. And that's where people start developing angina and or chest pain. So increased oxygen demand by the myocardium is supplied by dilation or widening of coronary arteries. So if your body feels like it needs more oxygen, it will start shunting blood from your extremities, causing widespread vasodilation, which will help with the increased oxygen demand as well. So dilation will cause the coronary arteries to get wider, causing for more blood supply, which then will transport, in theory, more oxygen. Stroke volume is the volume of blood ejected with each ventricular contraction. All right, so coronary arteries and blood vessels that are supplied blood through the heart muscle itself. So we have coronary arteries. There's a right and left coronary artery that's in there. People have heard, oh, I had a coronary. Those are your major blood supplies that start at the first part of the aorta going into the heart itself. With those becoming blocked at some point due to poor lifestyle choices, can cause a patient to have significant chest pain and or go into cardiac arrest. And we start seeing blockage, and I'm sure you guys have heard the term Stemi before, which is an ST elevation myocardial infarction, or STEMI. Those are patients that have blockages. So looking at these diagrams here, and it's kind of small on my screen to see, you can kind of see where the arteries are located. You can see how it pushes through. You notice how the center of the heart doesn't have any arteries actually attached to it, right? And this is why. We need to make sure we have proper blood supply as it does through diffusion and osmosis pulling it through. So we have the left pulmonary artery, the left main coronary artery, as you can look at the top screen here, the circumflex branch of the left coronary artery, anterior descending branch of the left coronary artery, and the coronary vein. All these actually do mean something more towards the ALS side. What I want you guys to be familiar with for testing purposes is just have an idea of where these are located, not so much what you're going to see on an EKG, because we're not going to teach you how to read 12 leads. But all these different arteries, circumflex, pulmonary artery, to the coronary artery, to the anterior descending artery, and things like that, all show up in an EKG when a patient's actually having a STEMI. We can actually tell which artery is actually having the blockage just by looking at a bunch of squiggly lines on a piece of paper. So arteries supply oxygen to different parts of the body. Obviously, we have the right and left carotid, which helps supply blood to the brain itself. We have the right and left subclavian veins, or arteries as well. So think of the clavicle. Those are going to be below the clavicle of the body, so up by your shoulders. Those are also major blood supplies as well. We have the brachial artery that runs right down underneath the bicep that helps supply blood to the upper extremities. The radial and ulnar arteries as well. Those also help supply blood to the upper extremities. The right and left iliac artery, those go down into the pelvis, which then go down into the right and left femoral arteries. Those can be palpated if you actually take your fingers, put them into your groin area, and push hard enough so you can actually feel a pulse. Those will be your femoral arteries pulsating, pushing blood into your lower extremities. And then it goes down into the right and left femoral, which goes into the anterior and posterior tibial and peroneal arteries, which help supply blood flow to the lower extremities. So going in more to the vascular system, we have arterioles and capillaries, which are smaller vessels. So remember, we start with an artery, which then goes into an arterial, which then goes into a capillary. Remember, at the capillary bed, this is where gas exchange is actually happening. So the capillaries connect arterioles to venules. So if you look at a picture of it, you'd see the bigger artery coming in, which then it gets smaller, which goes into an arterial, which then goes into multiple capillary beds, which are all in the top layers of your skin. And we'll talk about bleeding here in a second. With that, then the oxygenated blood then gets changed out with deoxygenated blood. Deoxygenated blood then goes to the venule, which is very small, which are the smallest branches of the veins, which then goes into the vein itself. At that point in time, it goes into the vena cava, which returns blood back to the heart. But the vena cava is going to have deoxygenated blood going back in from the top and the bottom of the heart through the superior and inferior vena cava. And that is going to be the last part of your blood supply going in, deoxygenated before it picks up new blood. I'm sorry, oxygenated blood, not new blood. So blood consists of a bunch of different things. We have red blood cells, which help carry the oxygen, like hemoglobin, things like that. We have white blood cells, which help fight infection. So you can see elevated white blood cell counts and be like, oh, that patient has an infection somewhere. Or you can see a patient that has no white blood cells, and those are going to be more of your immunocompromised patients. With them, you'll see a lot of immunocompromised patients that are on chemo or cancer treatments. We have platelets, which help blood clot, and plasma, which is the fluid the cells float in. So platelets are very important, especially when we're helping with blood clotting. Now, patients that are on blood thinners have very low platelet counts because remember, the blood is being thinned out, so we don't want to see clotting actually happen. There's also different clotting factors that are out there as well, which we're not going to get into at the ENT level. But patients that have different blood disorders or clotting disorders will actually know what they are. They'll let you know ahead of time, hey, I have a bleeding disorder, and we need to go from there and start treating the patient more aggressively because these patients can actually bleed out. All right, a little bit more about blood pressure. So blood pressure is the force of circulating blood against artery walls. So now we go to systolic and diastolic. So systolic blood pressure is the maximum pressure generated by the left ventricle. So think of your left ventricle contracting, pushing blood through the body into our core and into our extremities. We're looking at the systolic blood pressure being the max pressure, so pressure in motion going through the system. Your diastolic pressure is the pressure against artery walls while the left ventricle is at rest. So what's happening is your heart depolarizes, causing electrical conduction to push the left ventricle to squeeze it, to push blood throughout the body. Then we have something called repolarization, where the electrical conduction system's repolarizing, building up ready for that next jolt to push down through. And at that point, your arteries walls should be at rest. And that's when we start getting into the importance of blood pressure. Because if you have a patient that has a blood pressure, let's say 220 over 110, keep in mind that the normal blood pressure we're looking at is 110 over 70. You got to consider that's a lot of pressure on the walls, even at rest. So are your arteries really getting rest at all? And that can cause for a lot of other problems. And remember, we do have arteries that go through the head as well, in the brain. And those are not going to be as strong as our aorta or brachial artery and things like that. We just have arteries that run through the entire body. So by having a high blood pressure on a patient, that could lead to a hemorrhagic stroke or a bleed, and or a stroke in general, because the blood pressure is so high that it could potentially cause clots. You also got to look at irregular heart rates as well. So you guys can actually start seeing the importance of how important blood pressure really is, and make sure we're actually getting an appropriate blood pressure, and how important it is to actually listen and be able to pick up on that systolic, but also the diastolic pressure as well. So a pulse is felt when blood passes through an artery during systole. So peripheral pulses felt at the extremities, and then central pulses are felt near the body's trunk. So our central pulses that we're going to find are going to be our carotid pulses. So to locate a carotid pulse, you're going to take your hand and put it onto your neck. You're going to find your trachea in the center. You're going to go to either the right or left of the trachea, and you're going to find a spot not too far off the trachea itself. You're going to put a little bit of pressure. That's where you're going to be able to find your carotid pulse. That's going to be your central pulse. Peripheral pulses are felt on the extremities. So let's go over all those. The first peripheral pulse you can find is a brachial pulse, and for an adult, it's a little bit harder to locate. But what you do is take your arm and stick it straight out and go underneath your bicep. And if you get underneath the bicep, you can feel a brachial pulse. The next pulse on the upper extremity you're going to be feeling for is going to be your radials. And radial pulses are going to be very important as well, especially when they're doing any kind of assessment. Those are going to be felt on the thumb side. Just slide down the wrist a little ways and put a little bit of pressure. Tricks of the trade, more of the real world stuff. With elderly, sometimes it's hard to feel a pulse. Maybe you're pushing too hard and occluding it, and that can happen. Because their pulse rates are not going to be as more bounding as ours would be at a younger age. And then another thing as well is you may just have to maneuver the wrist a little bit, because just the pressure of the skin being pulled by the wrist bending may just cause enough for the pulse not to be felt. So just sometimes maybe a small readjustment will actually help you. Moving down to our other central pulses as well, looking down the lower extremities. Our other central pulse would be our femoral pulses. So we can check those as well to make sure we have good blood flow. Once we get past that, we're going to look more to our peripheral, and our peripheral pulses are going to be felt in the lower extremities, called the popliteal pulse. So that is located on the back side of your knee, in the groove there. So if you guys want to try feeling for that, you can at home. As we move down towards our lower extremity, down to our feet, we have something called a tibial pulse, and that will be felt more towards the medial side of the ankle. Remember, medial being midline, towards the midline, lateral being towards the outside. And then we have something called dorsal pedal pulses, which can be found. So if you locate, the big toe and the next toe over, you feel that really quick between that and kind of slide the fingers up.
You had the kids. They're at my house. My other older grandson.
I'm going to mute that. All right. Continuing on. So the dorsal pedal pulse will be felt between the big toe and the next toe over. Just kind of slide up a little ways. Usually you can find it there. One thing to keep in mind when you are checking for pulses is to make sure that you mark those when you find them, especially on the feet. There's nothing wrong with taking a pen and marking a patient's skin, because we need to go back and find it again. Sometimes it's hard to find and locate. So when you find it, mark it. And here are different pulses that we were talking about before and how to find them. So the dorsal pedis pulse they're looking for is up a little bit higher in the ankle. I found it even just above the big toe, between the big toe and the next toe over. But these are the different locations, anatomy and physiology-wise, to be able to locate them. All right, so cardiac output. So cardiac output is the volume of blood that passes through the heart in 1 minute. So the way to figure and calculate cardiac output is taking the patient's heart rate, multiply it by the volume of blood ejected with each contraction, which is called stroke volume. Perfusion is the constant flow of oxygenated blood to the tissue. So when a patient goes into shock, we talked about inadequate state of tissue perfusion. That's because we're not getting that oxygenated blood to the cells, causing a patient to go into shock, hypotension, tachycardia. These are requirements of good perfusion. If we don't have good cardiac output, we don't have a decent heart rate, we don't have good blood volume being ejected through stroke volume, then we're not going to get good perfusion. If perfusion fails, cellular and eventually patient death does occur. So we need to make sure patients are being perfused appropriately. And there are different ways patients can go into shock, which we talked about in the previous chapters. Patients that go into shock can be from hypovolemia, so that could be fluid depletion, as well as bleeding out, losing fluids that way. We also have other types of shock. Remember, what out there would be more of your distributive shock, so your anaphylaxis. Other ones would be like sepsis, which causes widespread vasodilation. So there's a lot of other things that are out there as well that can cause these patients to go into shock and make it so they don't have good perfusion. So we got to be able to look into that, look at our assessments to find out exactly what is wrong with this patient, how we can fix this problem that's currently there. Other ways of helping with shock, obviously, is laying them down flat, so we have more of a distributed load through the body. It makes it easier for the blood to pump, the heart as well to pump the blood through the body by laying down flat. And what we also do is something called a Trendelenburg position, where we take the patient's legs and we elevate them about 12 inches off the ground. And that allows for blood flow to kind of push back towards the core to increase the blood pressure. And the last thing we need to do, last two things I should say, is put them on a high flow non-rebreather for the shock patient. So make sure we give them good oxygen administration and also keep the patient very warm. So blankets, heat packs, whatever we need to do to keep the body warm. All right, so chest pain, a little bit of pathophysiology behind chest pain. So chest pain usually stems from ischemia. So that's an inadequate state of tissue perfusion. Ischemia is when we're not getting, which is decreased blood flow, which means we're not getting enough oxygen in. So ischemic heart disease involves a decreased blood flow to one or more portions of the heart. And if blood flow is not restored, the tissue dies. Once it dies, it's called infarction. So we want to make sure these patients are getting oxygenated, but they also may need something like vasodilation to help with that ischemia. And EMTs have the ability to assist with a vasodilator, otherwise known as nitroglycerin. So Ethereal Sclerosis is a buildup of calcium and cholesterol in the arteries. As you can see in the picture to the left-hand side, lower picture, it's something called plaque. So we start getting narrowed arteries versus looking at the cross-section we see over here with the arterial wall with normal blood flow, there's no plaque buildup. So where we have plaque, we have a decreased blood flow, which therefore can also, in turn, start causing chest pain. And we start seeing that ischemic heart disease start kicking in. So if patients have plaques, are developing some chest pain, what they can do is go into a PCI center where they can do a cardiac catheterization. They say, oh, we found some plaque buildup. We're going to go in and do a routine cardiac catheterization and place a stent in place, which is a metal type mesh that kind of inflates, pushing the plaque up against the wall, allowing for better blood flow. Back in the year, many years before I even started practicing EMS, they used to go in with something called the Roto-Rooter, and they'd go in and break up the plaque in hopes to clear up the arteries. Well, the problem with doing that is they realized is that people that were having plaque breakups, where does that plaque end up? It doesn't just disintegrate, it doesn't go away. It moves down the arteries. Next thing you know, it's up in the brain, causing a stroke. So they realized that's probably a bad idea. So now they just put a stent in, which makes the artery have a better passageway to get through and causes the plaque to kind of stay right where it is and not grow anymore. Patients that are put on, that have stents placed, are usually put on Plavix, which is a blood thinner, and usually they're on that for like the first 6 months. Then they may be put on some other kind of blood thinner after that. So looking at this again, fatty material that accumulates with age. So the older you are, the higher chance you have for plaque buildup. Plaque buildup is caused by eating all the fatty foods that we eat. And a prime example, well, this is Fair Week. So people go to the fairs and they eat the fatty foods because, well, they want to try it out. Sometimes it may be the last fatty food you eat. So a thrombolism is a blood clot floating through the blood vessel. So if a clot lodges in the coronary artery, we start having what they call an acute myocardial infarction or acute AMI, which then results. So we talked about that a little bit in the previous slide, where the patient has the plaque buildup to the point where it can break free, causing a clot in a major vessel. If we have an occlusion, that's where we start having bigger problems. So I want to show you guys here in a second. I'm just going to turn this off. Here. Let me go to... So can you guys see my screen okay?
Yeah.
Yeah.
Yeah. Yep.
I don't know if I can make this bigger or not.
Yeah.
So this one here, what you guys are seeing here, this guy's having a massive heart attack. Was one of the calls that I had. And if you can see the mouse on the screen, where you see V1, V2, and V3, this guy's having what they call a septal anterior Mi. I'm trying to find, so this one here. That's tachycardia. Let's see. Well, let's see if I can find it here somewhere. There's one for a Stemi I want to show you guys. And I actually have the pictures of it. So I can actually show you, because I can talk about it all day until you actually see it. It's quite amazing to actually see what the blocked vessel looks like. Let's see. Pretty sure it was in here. I probably missed it somewhere. Here it is. So this was a call that I had that I actually made a case study out of. And in this, okay. So this patient here came into the hospital. So we actually found this patient with a 911 call, brought him in. He was having a acute MI, as you can see, looking at this picture. I know you guys don't read EKGs, but where my pointer is V3, V4, V5, this guy was having a massive MI, acute MI, based on obviously plaque buildup, looking at the heart. As he was in the emergency room, if you look at this one here, patient went into ventricular tachycardia, actually went into cardiac arrest. While being in cardiac arrest, looking at this one here, You can look at what they call ventricular fibrillations. Remember that whole thing about the jello I was talking about? Heart shaking like jello. We performed a defibrillation, so that's a shock. Back into, again, ventricular fibrillation. CPR was done. Another shock delivered again. And then went into a sinus tachycardia, so a heart rate of greater than 100 here. We got pulses back. The guy actually woke up, and we transferred him to Catholic Medical Center. We had a cardiac catheterization done. So this is a picture of his arteries here. So if you look at, can you guys see my mouse on the screen?
Yes.
Yeah.
Yep.
So do you see where it says before and the arrow points to that artery right there? Okay. That's about a 90% occlusion of that artery. Because of plaque buildup, they went in and they did a scan. So what they do is they go in through the femoral artery or the radial artery with a catheter. They go up into the heart and they inject dye, and they take multiple pictures as they're doing. This is part of a cardiac catheterization. So they take multiple pictures of this. As they're doing that, they're snapshotting it, looking at the dye going through. And you notice how, if you look down through here, you notice there's not a lot of dye. You really can't see a lot of the other vessels coming through the heart, right? Because this has got a 90% occlusion. You can't even see anything there at all. They go in there with a catheter and they place what they call a stent. And the stent, obviously, remember I mentioned before how it increases, making the vessel bigger. The after effect looks like this. You see how it's a lot bigger now, and you can actually see the arteries going all the way down to the bottom of the heart? That's what a cardiac cath does when they go in. And patients have had, 1, 2, 3, 4, 5 stents at times placed to get arteries opened up, depending on where all the blockages are. So I figured instead of me just talking about it, I could show you pictures of what it actually looks like. And I wrote a whole case study on this specific call, which is why I have a lot of these pictures on here that I transported, and then transferred to Catholic Medical Center when I worked for Stewart's Ambulance. So again, full recovery, home within days. He was home, fully recovered, back to living a normal life. This guy was in cardiac arrest because it happened at the hospital. Medications were given, things were done appropriately, and this guy survived. So I figured you guys would want to see that. Other rhythms as well after the fact.
That's crazy.
Yeah, so that's what it looks like when people go in for a cardiac catheterization. So I felt that would be a good thing to show you guys to kind of see what that looks like. So going back to this slide here, again, so the thrombolism, so the blood clot floating through the vessel, it got caught there, plaque buildup, caused the guy to have chest pain, and because it was the location of that caused him to go into ventricular fibrillation, so the shaking of the jello, causing the heart to have no electrical conduction, or unorganized, I should say, none at all. That'd be a systole. If, again, causing an acute MI. A little too far there. All right, so coronary artery disease, obviously a leading cause of death in the U.S. Controllable AMI risk factors would be cigarette smoking, high blood pressure, high cholesterol, high blood glucose levels, diabetics, lack of exercise, and obesity. These are all comorbidities that can cause a patient to have an acute MI. So if you're a non-smoker, you control your blood pressure with medications, and/or you're in good shape. You make sure your cholesterol is within normal. Those are what they call LDLs. So HDLs are good. Think of H as happy cholesterol. That's good stuff. But your LDLs need to be low. Checking your blood glucose regularly, obviously exercising, and trying to stay within a good weight will help you. Uncontrollable acute MI factors would be older age, family history, coronary artery disease, race, ethnicity, and also being male, because men have a higher chance of having heart attacks. Acute coronary syndrome also is caused by a myocardial ischemia called angina pectoris, or in the acute MI. So the angina pectoris is going to be the patient that has prescribed nitro at home. They're up, they do some little bit of exercise, they develop chest pain goes away. That's what they call stable angina. Your unstable angina are going to be your patients that, let's say they're doing some work, the chest pain's there, and it just doesn't go away with rest. It just stays and stays and stays. So they start popping nitro like it's candy. These are going to be more of your unstable angina that can turn into acute myocardial infarction. We want to prevent that from happening. So a lot of times these patients need oxygen. They need vasodilation with oxygen to help reduce that. If chest pain is not being relieved with nitroglycerin, we need ALS on board either way, so they can give something like fentanyl or morphine as a narcotic, as an opiate, to help reduce that pain. Because as long as there's pain, it puts stress on the heart as well as also not having oxygen. So we got to try to control that pain level. So angina pectoris occurs when the heart's need for oxygen exceeds supply. When you start having that crushing or squeezing pain. This does not usually lead to death or permanent heart damage, but should be taken as a serious warning sign. These are patients that have the nitroglycerin prescribed to them. Another interesting thing is something called Levine's sign. So Levine's sign. If you've ever come in contact with a cardiac patient, again, this is not diagnostic. It's just something that's out there to kind of help you with some of your assessments. If you have a patient with Levine's sign, so if you take your hand on your chest, everybody put your hand on your chest for a second. I know I can't see you guys doing it, so do as you wish. And you place your hand over your chest, and then the hand is wide open. Okay, not like in a fist, but wide open on your chest. That usually indicates more of a musculoskeletal issue versus an actual heart attack, versus you making a fist over your chest saying, "This hurts." Okay? It gives you the sign of squeezing, like something squeezing your chest. That's more leaning towards a acute coronary syndrome or a cardiac issue. Again, don't make that your only part of your assessment. So, Kelsey, to answer your question, I've seen 5 or 6 planted at once. However, if a patient has multiple vessel occlusion, they have to go to a center that can perform open heart surgery, and that's what they call a coronary artery bypass graft, or a CABG, where they go in and they do multi-vessel removal. So they can actually take out vessels or bypass vessels that are there to assist. Does that answer your question? All right. So unstable angina in response to fewer stimuli than normal. So we talked about the unstable stuff. So patients that really doesn't have any relief to that. Your stable angina is really by rest, or they can take a nitro and it goes away. That's stable. But again, if they're popping nitro like it's candy, and you get that call for patient complaining of chest pain and has taken 6 nitro with no relief, that's when you start saying, oh, this is probably not a good thing to have without having a paramedic and responding. They got to help with that. So treat angina patients like an acute MI. So acute MI pain signals actual death of a cell in the heart muscle. The thing about heart muscle, okay, once dead, the cells cannot be revived. They're dead. There are clot-busting medications called thrombolytics, or fibrinolytics as well, that kind of help with the thinning of the blood to help prevent it. Drugs or angioplasty within the first hours prevent damage. Immediate transport is essential, and we want to make sure they get to a PCI center. When you guys do your ride time up here at Action Ambulance, we're an approved service by the state with a medical director approving this. we actually carry a fibrinolytics on the ambulance for STEMI patients, and it's called heparin. We actually carry the bolus dose, which is 4,000 units that we can give, up to 4,000 units, based on 60 units per kilo. So we carry this kind of medication on our ambulance because we are transporting these patients to a PCI center, which is Wentworth Douglas Hospital in Dover. And if they can't take it, then we go down to Portsmouth Hospital in Portsmouth. If these patients are brought to a hospital, they're usually given TNK and Plavix, and they're usually started with it. So if you bring like a STEMI patient, let's say to Huggins Hospital in Wolfboro, when they come in, they're gonna do an EKG. Again, they see, oh, it's a STEMI, they're having a heart attack. They start off with aspirin, they give nitro, they do TNK and Plavix for your blood thinning, and your clot busting. That's your TNK. So blood thinning, clot busting, and then they give heparin, and they bolus, and then they do a heparin drip after that as a maintenance infusion. Then they call an ambulance service. You're out the door in 20 minutes, going to a cath lab. So that's kind of like the process that goes through in order to get these patients where they need to be. So you'll hear the term time is muscle. It is, because heart muscle cannot be revived once it's dead. When the cells are dead, it's dead. So again, we got to make sure these patients get to the appropriate center. I think I've hit that enough, and you're probably going to hit it even more later with this. Time is muscle. So signs and symptoms of acute MI would be weakness, nausea, and sweating, chest pain, discomfort, or pressure, lower jaw, arm, back, abdomen, or neck pain. So when you're doing your OPQRST, and they say, does the pain radiate anywhere? That's going to be to the lower arm, jaw, chest, abdomen, back. Any kind of regular heartbeat or syncope, which is fainting. So feel for radial pulse. Remember, I told you guys look for 3 different things: rate, rhythm, and quality. We want to look for all 3 of those. Shortness of breath or dyspnea, another name for it. Nausea, vomiting. Pink frothy sputum, which is really bad. Those are patients who are more into congestive heart failure as well. And obviously sudden death, cardiac arrest. AMI pain differs from angina pain. So again, not always due to exertion. A lot of times exertion will cause angina, but AMI pain, just you can be sitting on the couch and all of a sudden develop chest pain. Last 30 minutes to several hours. This can last that kind of amount of time. So I mean, I've had patients that have had STEMIs that woke up in the morning. Oh, my chest didn't feel so good, so I just kind of brushed it off, thinking maybe it was like some gastric reflux or some heartburn. And then they call 4 hours later, I really still don't feel good. Maybe I'm having a heart attack. Right now, we're 4 hours into when the pain actually started. We look at a time of event to getting to a PCI center for 90 minutes. Now we're 4 hours in. Not always relieved by rest or nitro as well. AMI patients may not even realize they're experiencing a heart attack. Patients that are diabetics have something called neuropathy. Neuropathy can actually hide pain, or you could have a difference in pain. So normal chest pain, typical chest pain that we see in patients would be more of the pain on the chest radiating to the left arm, going down with arm numbness. But in females, the pain can be a little bit different. They may not have any chest pain whatsoever and develop back pain between the shoulder blades, and that may be the only pain they have. Diabetics, they may have upper epigastric pain, so just above the navel, but no actual chest pain. They could be having a massive heart attack. So never rule things out. If a female has back pain, get a 12 lead, because it may be a heart attack. You don't even know. Other findings or physical findings would be fear, nausea, or poor circulation. What they mean by poor circulation will be more of your diaphoresis, pale, cool, and clammy patients. Faster, irregular, or bradycardic pulse. Decreased normal or elevated blood pressure. As you can see, it can be any one of the 3. A lot of times you'll see your hypotensive or decreased blood pressures on patients that are having what they call an inferior wall MI. So the inferior wall of the heart is having an infarction, or the right side of the heart is having an infarction. normal or rapid and labored respirations, and patients express a feeling of impending doom. I am going to die. I can see the light coming in front of me. So there are 3 serious consequences of an acute MI. Sudden death resulting from cardiac arrest, a patient going into cardiogenic shock, so blood pressure's dropping to the point where they actually need something like a pressor to keep them alive, or congestive heart failure where their lungs are filling up with fluids based on the patient having a left-sided failure of the heart. So your left ventricle not pumping effectively, causing it to back up. Again, 3 different things, all can cause an acute MI or consequence from a heart attack. So a dysrhythmia of the heart, or heart rhythm abnormalities. We can have something called premature ventricular contractions. So that's going to be your ventricle firing prematurely. Now, the question would be are they perfusing or are they not? Again, you're not going to be able to see those unless you do an EKG, which we're not training you guys how to read those at the EMT level. But premature ventricular contractions can cause other extra beats. Now, if you drink a lot of caffeine, you drink energy drinks, you may actually develop these on your own. Are they dangerous? If you get a couple a minute, not a bad thing at all. You get 4 or 5 in a row, that's what they call ventricular tachycardia. And when you're in VTach, or when you're looking at the 4th one down, ventricular tachycardia, your heart is not going to be perfusing appropriately because your heart rate in ventricular tachycardia is about 200 beats a minute. You can be tachycardic, so anything tachycardia is a heart rate greater than 100. Keep in mind we're talking about adults only right now. And bradycardia is anything less than 60 beats per minute. Or you can be in ventricular fibrillation, which means you have complete disorganized electrical conduction system not working appropriately at all, causing your heart to fibrillate or shake. Defibrillation restores cardiac rhythms, which can save lives. So we want to make sure that we initiate CPR until a defibrillator is available, because without CPR, your heart is no longer pumping, right? But we need electrical activity. So again, defibrillation will help with that. An automated external defibrillator, AED, will only shock a patient or deliver a shock in a patient that is in VTach without a pulse or ventricular fibrillation. If there are any other rhythms, an AED will not defibrillate the patient. So they could be what they call asystole or asystolic, which means that they have no electrical conduction whatsoever. So the asystole part there. Nearly all patients will die. I have had very few code saves where I've had a patient in asystole and actually had them come out of the hospital even if we get pulses back. Usually when they're in VFib, we have a higher chance of survival. Usually the patients that are asystole as well reflects a long period of ischemia where they've had no oxygen going to the heart. Cardiogenic shock is often caused by a heart attack. So the heart lacks power to force enough blood through the circulatory system. Inadequate oxygen to the blood tissues causes organs to malfunction, often caused by a heart attack, which the heart lacks the power to pump, which recognizes shock in the early stages. We want to make sure we find that. So what they're saying with this slide here is that patients that are very hypotensive, pale, diaphoretic, they could be tachycardic. These patients need fluids right now to help pump. Other things that could also be lacking for power is electrical conduction. So they are bradycardic. They may need a paramedic to put on what they call the AED pads and start pacing them by doing little shocks to bring the heart rate back up to the normal rates. The other thing that may also need to happen as well is something called a vasopressor, which is given by a paramedic to help increase blood pressure and increase heart rate as well. Congestive heart failure occurs a few days following heart attacks. Not always, though. Increased heart rate or enlargement of the left ventricle no longer make up for the decreased heart function. So if they have a larger ventricle, it's what they call a cardiomyopathy, or otherwise known as like a floppy heart, where the muscles have stretched out to the point where they cannot contract fully, causing blood or to back up into the lungs, which therefore causes a patient to kind of like drown internally. So they become congested with fluids and may cause dependent edema as well. So we look at fluid in the lungs. That's what they call APE, or acute pulmonary edema, or a patient or what they call left-sided heart failure. If the right side of the heart starts to fail, we're going to start seeing extremity edema as well. So lower extremity, upper extremity. Those patients that have a hard time sleeping at night, they have to sleep sitting up in a chair because they can't allow for the fluid has nowhere to go. A lot of times you'll see patients like this, they're going to be on Lasix, or kind of diuretic to remove fluids, like hydrochlorothiazide being another one of the medications as well. Hypertensive emergencies, obviously systolic blood pressure greater than 180. Common symptoms would be sudden or severe headache, strong bounding pulses, or ringing in the ears. So if we start seeing some of these symptoms, these patients are in a hypertensive crisis, and we got to get their blood pressure down. So ways of doing this, obviously, at the EMT level, would be getting them to the hospital as soon as you can. Even at the paramedic level, we do not have a hypertensive protocol. So in the ER, they're going to get medications like labetalol or some kind of beta blocker to bring the blood pressures down to a normal rate. Another one would be something like nicardipine through a drip as well. Other hypertensive emergencies would be some common signs and symptoms of nausea, vomiting, dizziness, warm skin, dry or moist. Nosebleeds can also happen with hypertension, altered mental status, and sudden pulmonary edema. So patients that are in congestive heart failure after a hypertensive crisis that have acute pulmonary edema need CPAP. And that is a basic skill in New Hampshire, is applying CPAP to a patient. And also calling for ALS because it could be something called the nitro infusion, not just nitro tablets, but nitro infusion through a drip to control that blood pressure and also make a container bigger to push fluid out. So what you're doing with the CPAP is you're providing positive and expiratory pressure, keeping the lungs open longer. So if you guys were to take a deep breath in, purse your lips into like a kissing type position, purse your lips and breathe out, you notice it takes longer for you to exhale. That allows for the alveoli to stay open longer, and push in the CPAP will force that fluid out of the lungs into the what they call interstitial space. If untreated, can lead to stroke or dissecting aortic aneurysm, which you don't want that to dissect because, again, you can bleed out very quickly. Transport patients quickly and safely to the hospital and consider ALS assistance. An aortic aneurysm is a weakness of the wall in the aorta, susceptible to rupture. So again, bumpy roads, things like that, falls, can cause it to rupture. If it ruptures, you bleed out. Dissecting aneurysms also occur when inner layers of the aorta become separated. So the primary cause is uncontrolled hypertension, but you can have dissecting aortas from, let's say, side impacts of a motor vehicle accident, things like that. They can have your aorta can dissect. And I just recently took a patient to the hospital that had a leaking abdominal aortic aneurysm. Actually currently leaking. They made it to the OR fine, but again, it was leaking internally. And these patients need to get to an OR very quickly. Some AMI versus dissecting aortic aneurysm. So AMI, the onset of pain will be gradual with additional symptoms. A onset of pain which is abrupt without additional symptoms would be a dissecting aneurysm. Quality of pain, will be tightness or pressure. The dissecting will be a sharp or tearing pain. Severity of pain will be increasing with time. The pain for that will be maximal on onset. The timing of the pain obviously may wax and wane a little bit, but again, with the dissecting, it may not abate once it's started. It kind of just stays there. Radiation and region would be substernal. Back is rarely ever involved. If you have back pain, might be involved between the shoulder blades. And clinical signs, obviously, peripheral pulses will be equal in an AMI. Blood pressure is discrepancy between arms and decrease in femoral or carotid pulse. So you'll be taking blood pressures on both sides. So these are the differences between the two. Both still very critical. One needs an OR right away. The other one needs to get to a PCI center. Signs and symptoms, obviously, were very sudden chest pain. It comes on full force, and then you have different blood pressures in the arm. So again, if you think that the patient may have a dissecting aorta or an aortic aneurysm, get blood pressures on both arms. And transport patients quickly and safely. These patients need to get to an OR. So going into the actual scene, size up, again, scene safety BSI, don't forget about that. Ensure the scene is safe, follow standard precautions. Again, look at your nature of illness, obtain clues from dispatch, the scene, patients, family members, and bystanders. We want to make sure we form our general impression. If the patient is unresponsive and not breathing, begin CPR and call for an AED. If they are breathing, we want to do our airway and breathing assessment. If oxygen saturation is less than 95%, apply oxygen with a non-breather at 15 liters per minute. If they're not breathing, we want to use the BVM with 100% oxygen. If it's pulmonary edema, we want to apply CPAP and or using a BVM. And CPAP stands for continuous positive airway pressure. Circulation, if you want to check our pulses, skin, and cap refill, and consider treatment for cardiogenic shock. And then also we want to do our transport decision based upon the ability to stabilize life threats during our primary assessment. We want to transport in a stress-relieving manner. So again, if you're transporting, you're going lights and sirens, you're going 100 miles an hour to the hospital, do you think that's going to relieve any stress at all?
No.
Yeah, not at all. So again, run your lights if you need to, and transport appropriately. But again, if you're driving like Speed Racer going to the hospital, you're going to put more wear and tear and stress on this patient. Investigate the chief complaint, chest pain, difficulty breathing. And obtain a sample history from a responsive patient and use OPQRST. So I'll go over those again for you. Signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading to the illness or injury, onset, provocation, quality, radiation, severity, and time. So again, on the onset, when did the problem begin, or what did the patient think may have caused it? Did it come on all of a sudden? Did it come on gradual? What makes it better or worse? Taking a deep breath or palpation of the chest to make it worse? So do a chest assessment as well. Push on the chest, see if it makes it better or worse, or does it change at all? Ask the patient to describe their pain. Is it sharp? Is it dull? Is it a pressure? Is it squeezing, stabbing, tearing, burning? Does it radiate anywhere? Severity, using a scale of 0 to 10. 0 being no pain, 10 being the worst pain in your life. And how long has it been going on for? Once we get all that established, we're going to do our physical examination focused on a cardiac and respiratory system, looking at circulations, respirations, and at the same time, you also want to make sure you're getting your 12-lead EKG. Vital signs, obviously measure and record the patient's vitals, and if available, use pulse oximetry. If you have a cardiac monitor, you have all that kind of stuff built into it anyway, so put it all on, and make sure you get that 12-lead, because we want to make sure we have a baseline before treatments are even started. Then our reassessment, vitals should be at least every 5 minutes, or when the patient's condition changes significantly. Keep in mind that anything with cardiac, sudden cardiac arrest is always a risk. If it does occur, perform CPR, AED immediately. Reassess your interventions. If you gave nitro or assisted with nitro, reassess, see if the pain went down, see if it got better. Repeat another 12 leads, see if there's and have the medic look at it and see if there's any changes. Provide rapid transport and communication and documentation of everything that you do. Some other emergency care for the chest pain or discomfort, ensure proper position of comfort. If they feel better lying down, let them lie down. As long as there's no airway compromise, we can work with that. If the patient says they're short of breath and their oxygen saturation is 98%, give them oxygen because they're still short of breath. And depending on protocol, administer low-dose aspirin and assist with prescribed nitro. We're going to give 324 milligrams of aspirin. That's 4 81 milligram chewable tablets. And obviously nitro. Nitroglycerin dosing is 1 tablet is 0.4 milligrams. That's given sublingual under the tongue. So the effects of aspirin is a platelet aggregator. So aspirin prevents blood clots from forming or getting bigger. So aspirin, people think it's a blood thinner. It is not a blood thinner. It prevents further clot formation. They come in 81 milligram chewable tablets. The recommended dose is 162 to 324. Maine and New Hampshire protocol is 324 milligrams. Nitroglycerin comes in a sublingual pill, spray, or a skin patch which is applied to the chest. We're not going to be putting patches on chest, not at the EMT level. They may have a spray bottle. If they do, please do not spray it in the air to get it to test it out first. You don't want to inhale that stuff or get it on you. If you need to spray one spray first, spray it into a towel of some sort. And then obviously a sublingual pill, which goes underneath the tongue. What nitroglycerin does, they call it a vasodilator, so it dilates blood vessels. So it relaxes blood vessel walls, increases blood flow to oxygen supply to the heart, decreases the workload of the heart, and dilates vessels. What you're doing is making a bigger container to allow for better oxygenation. Side effects to this, though, will be a change in pulse rate, change in blood pressure, and also severe headaches can also occur from nitroglycerin. If you happen to have a side effect that it does occur, please make sure that you document that in your narrative. Contraindications of blood pressure systolically less than 100. Again, follow your protocols by state. Anything with a head injury, because remember, if you have a head injury and chest pain, and a patient has, let's say, a head bleed, and you give them a vasodilator, what do you think is going to happen? What do you guys think will happen with that?
Bleed out.
Yep, makes the bleed worse. Use of erectile dysfunction medications within 24 hours, or the maximum prescribed dose has already been given, which is usually 3. ALS providers can give as many as they need, but at the EMT level, since you don't have IV access, you have fluid to help with it, 3 doses is usually the maximum that you can give. When you administer nitroglycerin, ensure the medication is not expired nor contaminated. Ensure medication is prescribed to the patient, and make sure you wear gloves because it can get through your system just by touching your hands. All right. Cardiac monitoring. For an EKG or ECG to be reliable and useful, electrodes must be placed in consistent positions, which we already talked about and demonstrated in our last class. Basic principles should be followed to minimize artifact in the signal. Artifact is ECG tracing that is a result of interference. So I kind of showed you guys that last Sunday, where we actually had the patient shake a little bit, and you can see different, it makes a bunch of squiggly lines. So we want to make sure they sit nice and still, and have the patient sit nice and still. Tell them that. You may need to shave body hair. If they look like Sasquatch, you need to shave a spot to bare skin to be able to get a proper tracing. Please do not put it over the tops of patients that are full of hair. Attach electrodes to the ECG cables before placement, and we want to confirm electrode placement as well. So I gave you guys all those handouts during the last class we did. I'll see if I can upload that also to the platform as well, so you have it to be able to review. As you can see here, we have leads, our extremity leads or limb leads, they call them. And then we have our vector leads, which is V1 through V6. This is more part of our 12 lead. So remember, we're looking at the fourth intercostal space to the right and left of the sternum for V1, V2. V4 and V6 go fifth intercostal space. V4 is midclavicular, V6 is mid-axillary line, and then 3 goes between 2 and 4, and 5 goes between 4 and 6. So, Kelsey, piercings really don't make a difference at all. Doesn't matter where they are in the body when you're doing an EKG. However, if you are putting on an AED, take the piercings out because that can be considered a conductor. So if they have piercings in the spot where the AED pads go, take the piercings off and put the pads down. It's the same thing when you have a medication patch too. Take the medication patch off before putting the AED pads on, because it will melt the AED pads that are on there and it's actually causing burning to the patient. Once electrodes are in place, switch on the monitor and print a sample rhythm strip. If it shows artifact, confirm electrodes are firmly applied and the cable is plugged in. All right, so heart surgeries and cardiac assistive devices. Many open heart patient operations have been performed in the last 30 years. A CABG, or coronary artery bypass graft, which is a chest or leg blood vessel, is sewn from the aorta or to a coronary artery beyond the point of obstruction. So you take a vessel out of the leg and they move it up there. Percutaneous transluminal coronary angioplasty, which is a tiny balloon which is inflated inside a narrowed coronary artery. Patients who also have had open heart procedures may or may not have long chest scars, what we call zippers. So when you do an assessment for a patient who's unresponsive, they got a zipper down the chest, they've had open heart surgery, most likely. Treat chest pain in a patient who has any of these procedures the same as a patient who has never had heart surgery ever. Others have also implanted cardiac pacemakers. Pacemakers come in different forms as well. So pacemakers maintain regular cardiac rhythm and rate. They can be delivered through electrical impulse, through wires in direct contact with the myocardium, and they're implanted under a heavy muscle or a fold of skin in the upper left portion of the chest. With that being said, pacemakers can come in different forms. They have what they call a ventricular pacer, you can get an atrial pacer, or you can get what they call a dual chamber pacer, which is atrial and ventricular. Another thing they also can implant is a defibrillator. So you could have a defibrillator or a pacemaker or a pacer defibrillator combination. Oh, I didn't actually see your full thing about that. Sorry about that, Kelsey. So if you have anything with a piercing someplace that needs to be surgically removed, you can put your pads around it. But as far as doing an EKG goes, though, you're perfectly fine with that. You can place them, just move it a little bit over to the side. You should be fine with that. So this is a cardiac pacer. This is planted in the upper left part of the chest. So something, and I have seen them planted on the right as well, but most likely they're on the left-hand side. So usually when they're on the left, you don't have to really worry about the AED pads covering it. But if you do happen to see one planted on the right-hand side for some reason, make sure you put the AED pads like around it, not on top of it at all. So this technology is very reliable. Patient malfunctions can cause syncope, dizziness, or weakness due to the excessively slow heart rate. So transport patients promptly if they have pacer issues. Pacemakers can be continuous, or they can be what they call on demand. So if a patient has a fast heart rate or a low heart rate, the pacemaker can kick on and put it into a normal rhythm where they want it to be as well. So the automatic implantable cardiac defibrillators, otherwise known as an AICD, used by some patients who have survived cardiac arrest due to VFib. I've seen patients actually be shocked internally before, and they feel it. It's quite a thud to their chest. Monitor the heart rhythm and shock as needed. Treat chest pain patients with these devices like other patients having an AMI. The electricity is low in these and will not affect rescuers. So if you're touching the patient and the AICD goes off, you're not going to feel it. You're going to feel them jump, but you're not actually going to feel it though. Yes, Kelsey, that is true. They have special magnets that can actually deactivate pacemakers and defibrillators. We do not want to do that in the field, though. We have those in the hospitals. It's like a round circular magnet that has almost like a donut that they can be placed over it to actually deactivate them. But we don't want to deactivate those anytime in the field. Get them to a hospital. External defibrillator vest. So a vest with a built-in monitor, monitoring electrodes and defibrillation pads can be worn by the patient. So we're going to attach this. It's attached to a monitor using high-energy shocks. Do not touch the patient if the device warns it's about to deliver a shock. Stay away. The vest should always remain in place while CPR is being performed unless it interferes with compressions. 22 years of me doing this job, I have never actually seen that. These I have seen before. And they're what they call a left ventricular assist device, LVADs. But you also can have what they call a ventricular assist device that can be the right ventricle as well. But the most common ones, and these are patients that are waiting for heart transplants, have what they call an LVAD. The closest LVAD center is Tufts Medical Center in Boston. These guys do a lot of LVAD placements. So this is used to enhance pumping of the left ventricle. It may be pulsatile or non-pulsatile, which is continuous. The continuous ones, you're going to hear like a humming sound in those. That humming sound is a impeller spinning as the blood is going through. So if you go to check a radial pulse in these guys, guess what they're not going to have? A radial pulse. The patient or family can tell you more about the devices because they are obviously trained a lot better in them. And we're going to transport all supplies in the battery packs with the patient. Because if the batteries fail, the left ventricle stops pumping, therefore the patient dies. All right. Cardiac arrest. So a complete cessation of cardiac activity. So there's nothing left at this point. So absence of the carotid pulse, we took a carotid pulse, no signs of life, no more than 10 seconds, CPR is started. Was terminal before CPR and external defibrillation were deployed in the 1960s. These are AEDs. Again, different companies make different ones. They all have the same job function. Shock a patient that needs it. So analyzes electrical signals from the heart, identifying a VFib or a VTAC. and administers shock when the heart is needed. Aed models obviously require some operator interaction. All models require this. Most have a computerized voice synthesizer that advises steps to be taken, and most are semi-automated that we have. So the advantages to an AED obviously is a quick delivery of a shock, easy to operate. ALS providers do not need to be on scene because it does the shock for them. Remote adhesive pads, which are safe to be using as well, and they have a larger pad area for more efficient shocks. So it makes things a lot easier when defibrillating. Other considerations also, through all cardiac arrest patients should be analyzed. Not all require shocks because they may be what they call PEA or asystole. All patients in cardiac arrest should be analyzed with an AED. Asystole being flatline on electricity or pulses, electrical activity, PEA, usually refers to a state of cardiac arrest. So basically what you'll see is you'll see a normal rhythm, but there's no electrical conduction working with the heart to actually contract the heart. Early defibrillation is key. So few cardiac arrest patients survive outside the hospital without rapid sequence of events. Early recognition and activation, immediate bystander CPR, rapid defibrillation, basic and advanced EMS and ALS in post-arrest care. That's what they call ROSC. So ROSC is return on spontaneous circulation. And this is the chain of survival. So early defibrillation is key. So CPR prolongs the period of which defibrillation can be effective. Has resuscitative patients with cardiac arrest from VFib. So we're hoping in turn that this defibrillation will take the VFib and put it back into an organized rhythm. Non-traditional first responders are also being trained in AED use. So firefighters are being trained in this. Even the layperson is going through AED training. So ALS and post-arrest care, we need to make sure that we're continuing ventilation. We're going to be utilizing a VVM, utilizing a King airway as well, if needed, or some kind of supraglottic airway for New Hampshire providers. For Maine providers, make sure you guys use an MPA OPA. Assured blood pressure is greater than 90. We got to check blood glucose, and we're going to do a rapid transport. So integrating the AED and CPR. So work with the AED and CPR in sequence. So obviously you'll have the metronome that'll be going off. We're going to do our 30 compressions to our 2 breaths. Every 2 minutes we're going to reanalyze. And we're going to see if the AED has to actually make a shock or not. As far as maintenance goes with an AED, maintain the manufacturer's recommendations. They should be checked on a monthly basis on your trucks anyways. Make sure that the batteries are still good. And we should be changing out the batteries on a yearly basis. Read the operator's manual, document AED failure if there is any, check equipment daily at the beginning of your shift, and ask a manufacturer for a maintenance checklist if they have one. Most services that have AEDs have a maintenance checklist already in place. Report AED failures to the manufacturer and the U.S. Food and Drug Administration. Follow local protocols. Medical directions should approve written protocol for AED use. We already have all that stuff in place. And Con Ed with skill competency review is generally required for EMS providers. So we have to do AHA CPR every 2 years. As far as preparation goes, make sure the electricity injures no one. Do not defibrillate a patient in pooled water, and do not defibrillate a patient touching metal. When the AED is on, it says shock advised. Make sure you're not touching the patient when they shock, because that shock can be delivered to you as well. When it says analyzing heart rhythm, do not touch patient. Please do not touch the patient at this point. This happened the other day on one of the cardiac arrests that I was on up here, where a first responder was on scene and they continued touching the patient when it said analyze, and it said shock advised. it thought it had a rhythm. When they stopped touching the patient, I looked at it, I'm like, that is not a shockal rhythm. We deactivated the shock. So again, you may shock someone that doesn't need to be shocked at all because you are pushing on the patient's chest or moving them in one way, shape, or form when it picked up artifacts. Carefully remove any nitroglycerin patches or any kind of patches at all and wipe dry before shocking a patient. If the patient has a hairy chest, make sure you shave it to increase conductivity. Determine the nature of illness or mechanism of injury, perform spinal mobilization for trauma, and call ALS assistance if it's in a tiered system. So this is the cardiac arrest here. So when we do CPR, we're going to go over all this together anyways in 2 weeks. Begin chest compressions, attach the AED as soon as possible with the witness of cardiac arrest, and follow local protocol. After the AED protocol is completed, one of the following is likely: either you got a pulse back, no pulse is regained, no shock advised, or no pulse regained with a shock advised. Wait for ALS, continue shocks and CPR on scene. If ALS is not responding and protocols agree, begin transport. If the patient regains a pulse, transport is 6 to 9 shocks are delivered through transport. If an AED gives 3 consecutive messages every 2 minutes, no shock advised. For cardiac arrest, it says stop the vehicle, begin CPR. If AED is not immediately available, call ALS, analyze the rhythm, deliver shock. If indicated, resume CPR, continue resuscitation per local protocols. We usually don't stop the patient. We shock when they're moving vehicles. So again, we just continue transporting and do what we got to do, get the patient to the hospital. So that's how we work those. Again, we'll cover more of this in CPR on the practical day. Now, if AED is available, do not wait for ALS to get on scene. Notify the ALS of the cardiac arrest. Do not delay defibrillation. Right. So again, get these on these patients right away. Early defibrillation is the key for survival. So management of ROSC, we're going to monitor for respiration, see if the patient's breathing on their own. If not, we breathe for them. If we do that, we do 10 to 12 breaths per minute, maintaining oxygen saturation with 95 and 99%. Again, so if a patient needs a King airway, we're going to place a King or a supraglottic airway for this patient. We're going to assess blood pressures. We're going to assess these blood pressures every 5 minutes. If the patient is awake, we can follow simple commands. So again, sternum rub, trapezius pinch. If they are still unresponsive, obviously they can't follow commands. If they are more responsive, see what they can follow. And immediately begin transport. All right, so let's go over some review, then we'll take a 10-minute break and come back and do toxicology. And all the following are common signs and symptoms of cardiac ischemia, except what?
D.
Any other thoughts? I've heard one so far.
D.
B.
The answer is A. So let's go back a second here. So a headache. Remember, cardiac ischemia is lack of oxygen, which will cause chest pressure, shortness of breath, and obviously anxiety or restlessness. And you'll see anxiety or restlessness also in your pulmonary embolus as well. So kind of a blockage of the heart causing the body to become anxious. Number 2, so while palpating the radial pulse of a 56-year-old man with chest pain, you note that the pulse rate is 86 beats per minute and irregular. This indicates what?
D.
All right.
D.
Yeah, seeing a lot of D's online as well.
D.
D.
Correct. So a dysrhythmia. So the patient is what they call an irregular rhythm. An irregularity. A 56-year-old man has an acute myocardial infarction, so the heart attack, Stemi. Which of the following blood vessels became blocked and led to his condition?
D, but I'm not sure.
That the major vessel that goes to the heart.
B.
I'm seeing a lot of B's. B's, questionable B's. Yeah, the answer is B, the coronary artery. That is the major vessel that goes into the heart. Major controllable risk factors for AMI include, so controllable, not uncontrollable.
D.
So,
B.
yeah, controllable risk factors.
Oh.
What can
B.
you
Oh, C.
D.
C.
see? Okay, perfect. A patient with cardiac arrest secondary to ventricular fibrillation, remember that's the bowl of jello shaking, has the greatest chance of survival if
Oh God.
B.
so a patient that's in VFib, this is a shockable rhythm.
D.
So C.
All right, C it is. Remember, we want to get this patient defibrillated, so shock. So ventricular fibrillation is a shockable rhythm. Good. A 59-year-old woman presents with chest pressure. She is conscious and alert, but her skin is cool, pale, and clammy. Your first step in providing care or treatment should be what?
D.
This is a good National Registry question. She is conscious and alert. You've done your general impression. Her skin is cool, pale, and clammy, which means that she is not perfusing correctly, right?
So B.
The answer is B. So obtaining vitals is important. Use of nitro is also appropriate, but we have to get this patient oxygen. Because remember, if they're cool, clammy, and diaphoretic, the patient is not oxygenating appropriately, therefore becoming shock-like. So we want to make sure we oxygenate them first. Then we go into the rest of the stuff after. If a patient with an implanted pacemaker is in cardiac arrest, the EMT should do what?
C.
C.
I'm hearing a lot of C's.
A.
So
D.
we never withhold defibrillation regardless. And if they have one, we don't need to contact medical control. And we don't apply an AED over the implanted pacer, we go to the side of it. So the answer would be C. The main advantage of an AED is what?
D. D.
A.
This could be a trick question.
Oh wait, it is. Oh no.
All the above. So again, you might see things like that on the National Registry. We might think it's A, but it says you don't need ALS. But if you follow local protocol, they require you to have ALS en route. After administering a nitroglycerin tablet to a patient, the EMT should do what?
B.
B.
Oh, B.
B. Correct.
D.
Excellent. Number 10. So nitroglycerin is contraindicated in patients with
That would be
A.
think about what nitroglycerin does to
A.
vasculature.
A.
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 A is correct. Nitroglycerin can significantly drop blood pressure. All right. So why don't we take 15 minutes, come back at 8 o'clock. I kind of didn't give you guys a break. Get up, stretch, eat if you need to eat something, bathroom breaks, whatever. And we will continue on with chapter 21, which is toxicology. All right, we'll continue on. I just sent you guys an email. I'm sure you saw me doing that on the screen. It's a toxidrome handout that I made that will help with determining certain toxicological issues you might find on scenes. So hopefully it helps a little bit. It's a good handout to have. All right, so we're going to talk about toxicology. So I'm going to try not to go too in depth on this, but enough to get you guys understand the importance of trying to find issues on scene. So we get a lot of calls for different types of ingestions from mostly overdoses, whether it be narcotics, whether it be intentional, unintentional, to someone taking sleeping pills, to Benadryl, to whatever it may be, all the different ones that are out there. I want you guys to have an idea of what to look for in order to be able to make the appropriate treatment plans for these patients. So obviously, applying fundamental knowledge to provide basic emergency care and transportation to the ill patient. And toxicology, recognition and management of carbon monoxide poisonings, nerve agent poisonings, and also how and when to contact Poison Control Center. So the phone number for Poison Control, and you guys should all have this programmed into your phones, especially doing EMS, is 1-800-222-1222. You're going to really want to have that number programmed because basically any kind of overdose, we need to be contacting Poison Control. We're also going to cover the anatomy, physiology, pathophysiology for inhaled poisons, ingested poisons, injected poisons, absorbed poisons, and alcohol intoxication and withdrawal. So every day we come in contact with potentially poisonous things, whether it be acute poisoning, which affects 2 million people per year, or chronic poisoning, which is more common that we're going to see. With that being said, deaths caused by poisoning are fairly rare. So poisoning in children has decreased steadily since the 1960s due to the child-resistant caps on medication bottles. So that's helped out. And obviously, home-proofing, prevention, and things like that has also played a big part in this. Deaths caused by chronic poisoning in adults have been rising as a result of drug abuse. And we have seen a tremendous amount of overdosing, and a lot of it's been heroin, things like that, mixed with fentanyl, carfentanil, and everything else that's out there that's actually hurting even providers. So toxicology is the study of a toxic or poisonous substance. These are things you guys are going to want to know as far as what toxicology stands for. You'll see this on quizzes. So a poison is any substance whose chemical action can damage body structures or impair body function. A toxin is a poisonous substance produced by bacteria, animals, or plants. Substance abuse is the misuse of any substance to produce a desired effect. An overdose is a toxic dose of that drug. So if someone wants to use heroin, the desired effect obviously is to relax and get high. If they take too much of that, that becomes an overdose, which is a toxic dose of that drug that causes things a lot worse, to cause respiratory depression. Kelsey, you looking for the phone number again? Trying to type it in the box, but it won't let me do it. Oh, interesting. Okay. So 1-800 222 1222. Thanks, Sean. For some reason, it won't let me type in the box right now. I don't know why. All right. So the signs and symptoms of poisoning vary according to the specific agent that's there, which is why I gave you guys that toxidrome handout. So presence of injuries at the patient's mouth suggests the ingestion of a poison. So you may see like a caustic type chemical could cause a burning sensation around the mouth. So you may see discoloration. So these are kind of typical signs and symptoms of specific overdoses that are out there. So we have opiates, which are hypoventilation, respiratory arrest, pinpoint pupils, sedation, coma, hypotension. Some pathomimetics, which would be examples would be epinephrine, albuterol, cocaine, or methamphetamines, would be hypertension, tachycardia, dilated pupils, agitation or seizures, and hyperthermia. Sedative hypnotics would be like diazepam. I'm trying to read all these, they're kind of small. Midazolam. Other ones that I probably can't pronounce right now. Secobarbital. So you might see, so anything sedative or hypnotic would be like a slurred speech, sedation, or coma, hypoventilation, hypotension. Anticholinergics would be like atropine, diphenhydramine, chlorpheniramine, doxylamine, or Jimson weed is another one as well. You'll see tachycardia, hyperthermia, hypertension, dilated pupils, dry skin and mucous membranes, sedation, agitation, seizures, coma, delirium, and decreased bowel sounds. Then obviously our cholinergics, which would be like our organophosphates or nerve gases, we'd have airway compromise, and we use the acronym SLUDGEM, which is salivation or sweating, lacrimation, which is excessive tearing of the eyes, obviously urination, defecation, drooling, or diarrhea, GI issues like gastric upset or cramps, E for emesis, which would be like vomiting, and then M used to be meiosis, which is the pupils, pinpoint pupils, or muscle twitching. So all these have different types of treatments as well that we'll talk about here in a few minutes. So if possible, we want to make sure we ask the patient, what did you take? When did you take it or become exposed to it? How much of it did you ingest? Did you have anything to eat or drink before or after you took it? Has anyone given you an antidote or a substance orally since you've ingested it? And also, how much do you weigh? Because everything can be weight-based. These are also things we're going to need to know when we call poison control as well, to give them this information. We're going to try to determine the nature of the poison by looking around the immediate area for clues. Place any suspicious material in a plastic bag, and we're taking it with us to the hospital. Again, also containers at the scene can provide critical information. So bringing pill bottles with you, so that way we know how much it was in the bottle, how much is supposed to be taken on a daily basis, and when it was filled, can kind of give us a judgment of how much was taken or ingested if they're unconscious. If the patient vomits, examine the contents for pill fragments. Right, so yes, you need to look at the vomit and see if there's any pill fragments there. Make sure you wear proper PPE and note and document anything unusual that you see within that. All right, so how they enter the body. Well, emergency care for patients may range from a reassuring and anxious parent to performing CPR. We don't know what's going to happen when these patients ingest these chemicals or toxins or poisons. Most often, you will not be administering an antidote. At the EMT level, there's not much really can give. Definitive treatment can only be provided at the ED, so make sure you transport promptly. The emergency department has a lot more medications at their disposal to assist with any kind of antidote for these types of ingestions. The most important treatment you can perform is diluting or physically removing the poisonous agent itself. So how you provide treatment also depends on how the poison got into the patient's body in the first place. There are 4 routes to consider: inhalation, absorption through the skin, ingestion through PO oral, or injection through intravenous, and or injection into the skin itself through a needle of some sort, as we can see here. So all 4 routes of poisoning can also lead to serious or possibly life-threatening conditions. So again, we got to figure out what they took, how much they took, how long it's been in the system for, to be able to figure out how to determine treatment plans for this. If you are uncertain how to treat the patient, find the container if possible and contact medical control or the poison control center. To be honest with you, medical control is not going to be able to give you the information that poison control can give you. So we're going to contact poison control using the phone number that Steve and Sean posted for us. And again, let them know everything that's going on, and they're going to tell you exactly what to look for this and how to treat it. If you should have a paramedic on board or not. They tell you all this information. And on top of that, tell them what hospital you're transporting to, and they will fax over all the information about that toxin or poison to the hospital. And they'll also notify the hospital as well. You still need to do your call report anyways, either way, but the poison control will contact the hospital and let them know, hey, they're coming in with this. These are the treatment plans we need to give. Then it gets confirmed with the pharmacy and the physician, and they start treatment. So if you have an inhaled poison, move the patient to fresh air immediately. Again, if you suspect the presence of a toxic gas, we need to contact specialized resources, such as a hazmat team. Use of self-contained breathing apparatus, also protect yourself from poisonous fumes. If you're not trained to do this, you gotta wait for fire to show up to remove the patient. If you see multiple patients down, that should give you a hint. It could be something. It could be carbon monoxide poisoning. It could be a release of some type of other gas in the building. Again, if it's not safe and you see multiple people down, we probably shouldn't be going into that. Unfortunately, you have to watch those patients stay unresponsive and or pass away because we don't have the specialized equipment to go in. Now, once you get the right teams in, we're good to go. Just keep in mind that they may also have to be decon depending on what's going on. As you can see here, decon by the hazmat team after removal from the toxic environment. All patients who have inhaled poison require immediate transport. Remember, this gets into the lungs, gets into our system versus just on our skin. Be prepared to use supplemental oxygen and or BVM depending on the patient's status, and make sure that a suctioning unit is available, because a lot of times patients that inhale this kind of stuff, they start waking up, they may also start to vomit. Some patients also use inhaled poisons to commit suicide in the vehicle. So exhaust fumes containing high levels of carbon monoxide, we've seen this as well. Chemicals or detergent. This was actually pretty big years ago. Where they had the detergent suicides in tightly sealed vehicles, create a type of gas chamber. So they have to watch for that. So when you open the door, you may be overcome as well from that. So if you think it's a detergent type suicide or chemical suicide in a vehicle, make a gas chamber. If you suspect something's not right or you have that feeling, don't open the doors. Contact hazmat and have them remove the victim. This can affect the patient in many ways. It can affect the skin or mucous membranes or cause eye damage. So mucous membranes are like the backside of your lips, inside of your nose, backside of your eyelids. Chemical burns we're going to look for, rashes or lesions on the body. And we also got to think about systemic effects as well. So what's it doing systemically through the body as far as heart rate, blood pressure, respiratory drive, things like that. It's also important to distinguish between contact burns and contact absorption as well. So we got to look at the difference between the two. Do we see the burning, do we actually see burn marks, or do we see just absorption from like a powdery type substance or liquid? Some signs and symptoms would include a history of the exposure. Is it a liquid or powder on the patient's skin? Are there any burns, itching, irritation, redness of the skin, or typical odors of the substance? Our eyes and our nose can do a lot just to kind of figure out what potentially could be. Again, I wouldn't go around just sniffing any chemical. If you walk in and you smell something, usually that means, hey, something's not right, so we need to back away. So emergency treatment, obviously avoid contaminating yourself or others. If the patients need to get out, we gotta make sure we're protected to do this. If we start taking these patients that are completely exposed and throwing them in the back of our ambulances, now we're exposing the back of our truck instead of deconning them prior to. Get all the contaminated clothing off this patient, flush and wash the skin that's there to make sure we prevent anything further from happening to the patient and or to us, or maybe in the emergency department as well, by bringing this kind of stuff in. If the dry powder has been spilled, we're going to brush off the powder. We're going to flood the area with water for 15 to 20 minutes. Then we're going to wash the skin with soap and water. So we don't have the ability to do all this in the back of the ambulance. So this may have to happen in other ways. If a liquid has been spilled onto the skin, we're going to flood for 15 to 20 minutes. So you may be doing a lot of treatments on scene before you transport because we want to get this stuff taken care of right away. We don't want to bring this into the back of the truck. This is one way to flush the eyes. So when we do our next practical session, I will show you guys how to do this. It's a great way to flush both eyes at the same time. What we do is we take a bag of saline, from 1,000 bag of saline, and we use a drip set that we would use for an IV therapy, and we connect that into a nasal cannula. We put that into the eyes, and it helps flush both eyes at the same time. Now, if one eye is affected and the other eye is not affected, we don't need to flush both eyes at the same time. And what we want to make sure we do is we turn the patient onto their right or left side, but we don't want the affected eye running into the unaffected eye, so make sure you're turning it to the right way. We want to make sure we irrigate. So many chemical burns occur in an industrial type setting. So one thing before we even get into all this here, if you work in an area, it's good to know what industrial businesses that you have in your area and what kind of chemicals they're currently using. Unless it's top secret stuff, it's good to have an understanding of what's there. So you have body shops, you understand what kind of chemicals are in body shops, things like that. So that you can at least pre-plan for it. So if you get an industrial type injury, we know what we're expected to come into, hopefully. Usually with an industrial setting, they have safety showers and specific protocols for handling surface burns that might also be available to you. The hazmat team should also be available to assist you as well if you need hazardous materials team to come in. Ensure that you, your team, and the patient are thoroughly decontaminated before you come out. For us as EMS, normally we're in the cold zone. So in hazmat, there's 3 different zones. There's hot zone, where the actual incident's occurring. There's a warm zone. That's where decon usually takes place. And then in the cold zone, that's where everybody's been cleaned off, and EMS is usually standing by waiting. After decontamination, promptly transport to the ED for definitive care and obtain material safety data sheets, or SDSs now, safety data sheets, because of the whole global harmonization thing. They're called SDSs now. And make sure you have those available and bringing them with you. It is required by OSHA, Department of Labor, whatever your state uses, that you have SDSs available in every business. Whether it be online available or in paper, you can have one or the other. About 80% of poisoning is by mouth. So whether it be liquids, household cleaners, contaminated foods, plants, or drugs. This can also go from pediatrics all the way up to the elderly and how we handle these. Remember, there's household cleaners that are out there that look like Gatorade and other kind of drinks that a kid would want to drink. Also, we have our contaminated foods like botulism or salmonella, different plant, drugs, liquids that are out there as well. So usually accidental in children and deliberate in adults when they have ingested type poison. Because remember, the kids don't know better. They think a pill looks like a piece of candy. They go ahead and eat it, and next thing you know, they're having issues. So signs and symptoms would vary from the type of poison, the age of the patient, and the time has passed since the ingestion. That's why it's so important to make sure we get this information when we do our sample history and OPQRST to make sure we have this information for poison control. Also have an idea of how long it's been in. Signs and symptoms also include burns around the mouth, gastrointestinal pain, vomiting, and cardiac dysrhythmias, and sometimes seizures as well. So there's a pretty cool app that's out there that helps a lot of this, and it's not just using Hippocrates to look at medications, but it's an app called Wiser. I use it a lot whenever time I go to an industrial issue or some kind of chemical thing. And I keep it in my medical apps. And it's called WISER. I believe it's a free app that you can download, but it has all the chemical stuff in there you need to know. What was that?
Yeah, it's free.
Yeah. So I have it on my phone. I usually keep Wiser and Hippocrates, which is also free. Do not do the subscription on that. It's for doctors and medication stuff for Medicare and everything else. So you don't have to worry about any of that at all. But I usually I have Wiser on there, and I also use, like I said, Hippocrates as well. So two good free apps to utilize, especially for toxicology, because Hippocrates also has a pill identification on it as well that can help you identify pills if you don't know what they are, especially if they ingested them. So I would type those into the chat box. I just can't get into it. I don't know why. So we want to make sure with any kind of ingested poison that we treat the signs and symptoms and notify the poison center and medical control of the patient's condition. They need to know what's going on with these. Consider whether there is an unabsorbed poison remaining in the gastrointestinal tract and whether you can safely and effectively prevent its absorption. There is one medication that's out there that will teach you at the national registry level, and it's called activated charcoal. And that can help with absorption, as you can see here. Some EMS systems allow EMTs to administer activated charcoal. So again, always immediately assess the ABCs of every patient who has been poisoned. What they're going to do is they're going to take this, they're going to drink it. It's going to absorb, and it's either going to come out through vomit or it's going to come out through feces. And that's the difference between sorbitol or not, whether that's going to come back up or not. When we do the practical sessions, we'll go over medication administration even more in detail and how we handle stuff as well. So exposure by injected poisons include intravenous drug abuse and envenomation by insects, arachnids, or reptiles. These are usually absorbed quickly into the body and cause intense local tissue destruction. So some medications can cause what they call tissue necrosis and can actually destroy the tissue rapidly. These cannot be diluted or removed from the body in the field. So they're going to need antidotes for these to help remove these from the system. Or they may just have to wait till it wears off. They'll have to be monitored as well. So some signs and symptoms may also include weakness, dizziness, fever, chills, unresponsiveness, and excitability. So we want to make sure we monitor the airway. So again, going back to the National Registry stuff, anything you see with airway as an answer, for an assessment, it's probably going to be airway as the correct answer because ABCs always come first. So monitor the airway, make sure there's not any occlusion, make sure there's not going to be any swelling, provide high flow oxygen, and be alert for nausea and vomiting. If they're going to be nauseous and they're going to vomit, you have to sit them up, have them vomit into a bag, or we're going to turn them onto their left side, have them vomit onto the floor. Remove any rings, watches, or bracelets from the areas around the injection sites if swelling starts to occur. So if you think it's going to swell up, take stuff off the patient. So whether you want to cut it off or it cuts off circulation to the point where you can't remove it. So as far as the scene size up goes, a well-trained dispatcher can obtain information on a poisoning call, including proper protection needed, information pertaining to the MOI or NOI, number of patients involved, if additional resources are needed, and whether a trauma is involved. So hopefully these dispatchers are taking good notes and asking the appropriate questions. We're going to take standard precautions and look for clues that indicate the substance involved. So again, if you think it's something that's very toxic, you need to have hazmat there for, then make sure we make the appropriate call quick enough, because hazmat teams don't assemble very quickly. It takes time to get hazmat teams in place. So when we're doing our sides up, we want to ask the following questions. 1, is there an odor in the room? Is the scene safe? Are there medication bottles lying around? Is there medication missing that might indicate an overdose? Again, how to tell if something's missing? Look at the bottle, see what the medication name is, the date it was filled, the current date it is now, and how many are taken throughout the day. Are alcoholic beverages containers present? And keep in mind that people hide stuff, so check underneath beds, pillows, and things like that to be able to find containers. Are there syringes or other drug paraphernalia on the scene? If the room is dark, never kneel down on the ground, because you never know if you're going to go on a hypodermic needle. Right? So make sure you always have good lighting. If you don't have good lighting, then make good lighting. Bring flashlights in, whatever you need to do to make lighting good in that home that you're in, or even outdoors. Is there a suspicious odor that may indicate presence of a drug laboratory, like a meth lab? So again, if you smell something that's funny, a suspicious odor, and you suspect overdose as well, get out. Protect yourself. Determine the severity of the patient's condition. So obtain a general impression. So the general impression, again, are they sick or not sick? What do they look like when you walk through the door? Assess the level of consciousness by using your AVPU scale, alert, verbal, painful, unresponsive, and you also want to make sure you get if they're conscious and alert by utilizing person, place, time, and event questioning. If there's any life threats, fix the life threats. So if they're not breathing, breathe for them. If they're bleeding out, tourniquet, move forward. Do not ever assume that a conscious, alert, and orientated patient is in a stable condition. We still want to make sure that we also get vital signs to see how stable they actually are. Another thing with medications as well is with an overdose is medications may not actually act upon right off the bat. There could be something called an XR, an extended release medication, and those can actually take a little bit longer in the system over time. Other airway and breathing stuff, ensure that the patient has an open airway and adequate ventilation. If the patient has difficulty breathing or an inhalation injury, begin oxygen therapy by a non-rebreather between 10 to 15 liters per minute, and have suction available because these patients are susceptible to vomiting. And with circulation, we want to make sure that we assess the pulse and skin condition. And then we're going to make a transport decision to consider prompt transport with obvious alterations in the AVCs for the patients who have determined have poor general impression. Everyone who is exposed to a hazardous material must be thoroughly deconned by the hazmat team before leaving the scene. So those are going to be your operation level personnel that are doing decontamination. We don't want to transport a patient that's not deconned. And if you have a hazmat situation, also notify the hospital so they can set up their decontamination tents outside. So we want to make sure we investigate the chief complaint for history taking. If your patient responsive, begin with the evaluation of an exposure in the sample history. If your patient unresponsive, obtain history from coworkers, bystanders, friends, family members, medical jewelry, or wallet cards. So something to keep in mind. If their friend is unresponsive, they may not tell you exactly what they took. They need to understand that their friend is going to die if they do not give us the information that we need. So again, make sure that you paint that picture that this patient is sick, and we need to know exactly what they took so we can provide them the right treatment. Because if they make something up and give you something they didn't take, and the hospital says, yep, we're going to start this treatment, or you start the treatment in the field, and the patient has a bad reaction because you treated for something that's not exactly there, it can kill the patient. So you got to make sure you get the good information that they need to provide and the correct information. Obtain a sample history, which will help guide you on what to focus on as you continue the assessment. And we're going to ask the following questions. What was involved? When did the patient become exposed to it? And how much did the patient ingest, or what was the level of exposure? We want to know how much exposure they actually had. Other questions would be, over what period of time did the patient take or was exposed to the substance? Has the patient or bystander performed any interventions? And we got to get a patient's weight. Because again, weight can play a big factor in how much the patient can actually take. Then we get into our secondary assessment, where our physical examinations. So we're going to focus on the area of the body involved with the poisoning or the route of exposure. So if it's airway, we're going to focus on airway. If it's an injection site, we look at injection, but still monitoring ABCs. A general review of all body systems may help to identify systemic problems. So still do your full head-to-toe assessment. Palpate the abdomen, see if there's any discomfort, rebound, tenderness, and any changes. Get a full set of baseline vitals, complete set. And look for alterations in loss of consciousness, level of consciousness, pulse, respirations, blood pressure, and skin. Don't forget about body temperature. Blood glucose also plays a big factor in ingestions as well. So get a blood sugar, get good lung sounds, get a body temperature and continuously monitor body temp. Because some medications can cause hypothermia and some medications can cause hyperthermia. We want to reassess the adequacy of the ABCs. Again, we got to constantly check airway, breathing, and circulation because things can change on the snap of a finger. Repeat vital signs. Compare them with a baseline set. You want to look at what they call trending. So we're going to do a comparison, and then we're going to trend from there. Are we going to see elevated heart rates, lower heart rates based upon the chemical that was taken? Will actually help us determine where things may end up going. And again, medical control is going to be key for you. So also evaluate your interventions every 15 minutes for stable, every 5 for not unstable, or constantly for a patient who has consumed a harmful or lethal dose. So you may have to do vital signs every minute itself. So to answer the question that was written online to everybody here, so how do ED drugs work? So again, it's causing it is a vasodilator, but it's set for the specific muscle that needs to be vasodilated. Does that make sense? But also with vasodilation, it can also cause drop in blood pressure. So again, they may take the extra pill times 2, and that could lead to bigger problems when they're performing the act. It can actually decrease the blood pressure as well, causing a patient to vagal out. Does that make sense?
Yeah, and I didn't mean to make light of it there or anything, but I guess it. I mean, I honestly have no idea how they work, and I always assumed that it's something to do with increasing blood pressure rather than decreasing. But No, you've answered the question, and
Okay.
yeah. I thought it was going to be working the other way around, but apparently not.
Yeah, that's why we got to watch with nitrates when patients have chest pain, because if they're on the ED med, we're already vasodilating the system as it is and dropping their blood pressures. So just got to be careful. All right. So as far as treatment goes, again, we're going to support the ABCs, which remember is your most important task. We're going to contact medical control or a poison center to discuss treatment options. Go with poison control first, then contact medical control. Any airborne exposure, we're going to dilute with oxygen. So if you have a patient that has been exposed to carbon monoxide, you remember you're going to get false SpO2 readings. Okay, so if you have a monitor that checks SpCO, that would be way better for us to be utilizing. So if that's the case, make sure that we're monitoring that and giving high flow oxygen to replace the carbon monoxide that's attached to the hemoglobin with actual oxygen molecules. We're going to remove the contact exposure with water if we have any contact exposure, and consider activated charcoal for ingestions. Again, if it's a caustic ingestion, we need to be very careful, because if you give activated charcoal and they vomit it back up, that chemical that just went down through is now coming back up through the esophagus, which causes a repeat burning sensation. And remember, communicate and documentation. Document everything that's there. All right. So as far as EMS care goes, remember assurance and safety. Follow standard precautions. Perform external decontamination, which we've hit quite a bit. Remove tablets and fragments from the patient's mouth if there are any in there. If you need to use suction, or if you need to use your fingers to move stuff out, again, be careful with fingers so they can bite. Usually we just use suction. You can use a Yankauer to kind of remove them. If the pill fragments are too big, just take the Yankauer off, put the tube inside, and start suctioning it out that way. If the patient has any poisons on their skin, we either can wash it off or brush it off. But you got to find out if that chemical that's on the patient's skin is water reactive or not, because the last thing you want is to put water on something that's water reactive and causing chemical burns. So again, the safety data sheets will help you tremendously with that. And we're contacting poison control. We're going to assess and maintain ABCs, provide oxygen and ventilations if needed. We're going to treat for shock and transport the patient promptly to the nearest hospital. Some EMS systems also allow EMTs to give activated charcoal by mouth if needed. Activated charcoal binds to specific toxins, which are then carried out in the body in the stool. However, some activated charcoal, that's why the sorbitol is in there. Activated charcoal is not indicated for patients who have ingested alkali poisons, cyanide, ethanol, iron, lithium, methanol, mineral acids, or organic solvents. These will not absorb to these very well for the charcoal. Or anybody that has a decreased level of consciousness that cannot protect their own airway, because remember, they are drinking this as like a slurry going down their esophagus and their stomach to absorb this poison. If local protocol permits, you will likely carry plastic bottles of premixed suspension, each containing up to 50 grams of activated charcoal. These are some of the other names you'll find: Instachar, Actidose, or Liquichar. And they're usually for an adult or a child who is 1 gram per kilogram of body weight. So again, this is a weight-based medication that you're going to be administering as an EMT. So before you give a patient charcoal, obtain approval from medical control. When we have it, we got to make sure we shake the bottle vigorously. You also may need to convince the patient to drink it, but never force it in. We don't want them to choke. Record the time you administered activated charcoal, put it in your narrative, document your times. If the patient refuses activated charcoal, document the patient refusal, and transport the patient for further evaluation. So patients have the right to refuse specific treatments. Just forget, the main goal is get them to the hospital. So if they refuse it, document it. The side effects are constipation and black stools with this. If the patient has ingested a poison that causes nausea, he or she may vomit after taking charcoal. Again, the dose will have to be repeated if they do vomit it back up. If it's a caustic type chemical, we don't want them vomiting that back up. It's just going to cause further burning and more damage to the esophageal lining. All right, so over time, a person who routinely misuses a substance may need increasing amounts to achieve the same result. This is called developing a tolerance. So a person with an addiction has an overwhelming need to use substance at whatever cost. Almost any substance can be abused that's out there. With that being said, patients that use like heroin and things like that, who have become clean, may have a relapse but go back to their dose when they had a tolerance. And that's putting them into a state where they overdose. Because now they're going back to what they thought worked, but they're taking way too much. It's also important of the safety awareness and standard precautions. Remember, it cannot be overemphasized. We got to make sure we take care of ourselves. A known drug user have a fairly high incidence of serious and undiagnosed infections, including HIV or hepatitis. So again, repeat drug users, repeat things like that. We want to make sure we use complete, appropriate PPE. So at least a minimum, gloves, mask, eye protection in case they vomit, things like that. And if we have to go into the gowns, we have to go into the gowns. We want to make sure we're protecting ourselves at all costs. All right. So many calls for service also have a connection to alcohol use. So 1 in 10 deaths among working age adults in the United States can attribute to excessive alcohol use. We get these a lot. We see a lot of ETOH calls. A lot of times it's check for PD. We get on scene, assess. If a patient has an injury and they're intoxicated and do not want to go to the hospital, that is a medical control contact to find out if you can legally have them refuse care. Now, if they're completely trashed, again, they have lost their rights to make medical decisions, and we can take that right away from them as EMS providers and transport them to the hospital. Depending on the system, they may go by PD or they may have to go by ambulance. So alcohol can damage the liver, whether through chronic overuse or occasional heavy use by binge drinking. This can happen. I've seen a lot of this during college responses and things like that, but also, again, people that have depression can go on a binge drink, and next thing you know, they have liver toxicity, acute liver toxicity, and they become unresponsive, things like that. So binge can also be more damaging than chronic use, depending on the frequency of binging and the surrounding circumstances as well. Alcohol is a powerful central nervous system depressant. So it induces sleep, decreases activity and excitement, and by inducing sleep, they can also vomit with an unprotected airway. Dulls the sense of awareness, slows reflexes, and reduces reaction time. So again, you could have an ETOH patient involved in a motor vehicle accident because the reaction time was too slow. May also cause aggressive or inappropriate behavior and a lack of coordination, or they don't take well to authority when you show up. So again, PD should be present for this, make sure the scene is safe, and if it becomes unsafe, back away and leave. Alcohol also increases the effects of other drugs and commonly taken with other substances, like sleeping pills and alcohol. Doesn't usually mix. A lot of times it can put you into cardiac arrest because you become so hypoxic, you end up going into respiratory arrest and then cardiac arrest afterwards. If a patient exhibits signs of serious CNS depression, you must provide respiratory support. These patients here may also get intubated. So if you have a patient that's completely trashed, CNS depressed, where you might lose an airway, having a paramedic come on board to perform an advanced airway may be an option for this patient. Again, it's only temporary, but it's enough that the patient starts sobering up where they can be extubated and maintain their own airway at that point. If the patient's in shock, you still want to make sure you consider internal bleeding. Patients may also experience frightening hallucinations or what they call delirium tremens, DTs. These patients may need to get a benzodiazepine to kind of help with that. DTs are characterized by agitation, restlessness, fever, sweating, tremors, confusion, disorientation, delusions, or hallucinations, and seizures. So you got to pay attention to all these. DTs can actually kill somebody. Very, very serious, and these patients need to get to a hospital, and they need to get certain medications on board to help with this. And a lot of times they give a benzodiazepine like Ativan to help. And there's something called like an Ativan taper to get them through the system. All right, opiates or opioids. An opioid is a type of narcotic medication used to relieve pain. I know that you guys have probably seen a lot of this, especially with the heroin stuff being an opiate. So an opiate is a subset of the opioid family and refers to a natural, non-synthetic opioid. So the name opium, named from the opium in poppy seeds, from which codeine and morphine are derived from. So poppy seed bagels, if you get enough poppy seeds, it actually becomes it's opium in the poppy seeds that they make this stuff from. Excuse me. So again, things we're going to see with opiate abuse. We'll get to that here in a second. So synthetic opioids include meperidine, hydromorphone, which is other name is Dilaudid, oxycodone, hydrocodone, and methadone. These are the opiates. Opioids. So as you can see over here on the list on the left side, these are common opioids and opiates. So opiates would be more like your morphine, fentanyl, things like that would more be opiate stuff as well. Prescription opioids drugs are among the most commonly abused drug in the United States. The death rate from heroin overdoses tripled between 2010 and 2013, and it's only climbed from there. So we got to make sure that we're looking for the appropriate signs and symptoms of this. So these agents obviously are CNS depressants. With opiates and opioids, there's something called the classic triad. There's three things that you're going to see. Unresponsive, pinpoint pupils, and the third is decreased respiratory rate. It's a CNS depressant. These patients can go into cardiac arrest if they're not treated promptly. And the treatment for opioids is going to be naloxone. And that's going to be our treatment for that. That's the way we put in a blocker. With this, it helps block the more opiates getting into the opiate receptors in the body, which will then in turn have the patient start waking up. Again, it's only temporary, so the patient might need more Narcan later on down the road on your transport. Seizures are uncommon, but they can happen, so you got to prepare for seizures. A lot of times they'll be because they're so hypoxic, it puts them into a seizure activity. The patients usually typically appear sedated, unconscious, cyanotic with pinpoint pupils. So again, Narcan quickly will actually help these patients. The only thing is, though, and I know that PD carries Narcan as well, and fire departments, they carry the auto-inject nasal atomizers, and they're like a higher dose, so like 4 milligrams. What we do with EMS, we usually give 0.4 milligrams to start and work our way up to 2, because we don't want to wake them up. If they wake up, they can become agitated, they can become flushed, hypertensive, tachycardic. They can also start vomiting, lose their airway. They can also become very agitated to the point where they try to hurt you. So again, we try to keep them still unresponsive and transport them. and give them just enough Narcan to maintain their respiratory drive. So this can be given intranasal, intramuscular, or intravenous. So for the EMT, we're going to look at the intranasal, using a nasal atomizer for these. In many EMS systems, EMTs administer naloxone the intranasal route, which is true. And should only be used when the patient has agonal respirations or is apneic. Again, we don't want to wake these patients up because they can cause a lot more issue. So we want to place an oropharyngeal airway and ventilate the patient using a BVM prior to administering Narcan. Be careful with oral airways because remember, oral airways can trigger gag reflexes, and the last thing we want to do is have them vomit. So a lot of times nasal airways are the best ones to put in, so that way if they sit up and run away, they can pull it out of their own nose. In some areas, laypersons are permitted to administer naloxone. A lot of times the patients that get discharged, especially from rehab centers, the family members are given naloxone in case they relapse, or a lot of times the doctor's offices will hand this stuff out as well. So find out from bystanders that the patient actually was given naloxone. So sedative hypnotic drugs, obviously barbiturates and benzodiazepines are easy to obtain and relatively cheap. So CNS depressants can alter level of consciousness, and patients may appear drowsy, peaceful, or intoxicated. So again, when we go over, I'm going to go over the handout that I sent to you guys. I'll bring it up on the screen and kind of cover what to look for and the different types of potential ingestions or poisons that you could come in contact with. So these agents are usually generally taken by mouth. So some of the benzodiazepines that we carry in an ambulance would be like Valium, Ativan, and Versed are the three that we carry. Anything that ends in lam, so like midazolam, diazepam, things like that, anything that's in PAMs, those are usually your benzodiazepines. So occasionally the capsules are suspended or dissolved in water and then injected. A lot of times you'll see this. IV sedative hypnotic drugs also quickly induce a tolerance. So again, they may be using more and more and more. I don't see a lot of this in the field. I see more of the opiate than anything else, or I'll see like methamphetamine use and cocaine use as well. These drugs may not be given to people as a knockout drink. So your treatment is to ensure airway is patent, assess ventilations, and provide prompt transport with these. There's nothing we're going to be able to do in the field other than ventilate for them and kind of keep them breathing. Abused inhalants, so obviously acetone, toluene, xylene, hexane, different gases. They're found in glues, cleaning compounds, paint thinners, lacquers, things like that. Gasoline or halogenated hydrocarbons are also abused as well, and they're commonly abused by teenagers. I'm going to get to one in a second also for an inhalant, more of an inhalant through inhalation through the nasal passage. We'll get to that here in a second. So I don't think this is even listed in the presentations. So always use special care. So halogenated hydrocarbon solvents can make the heart hypertensive to the patient's own adrenaline. So obviously we're seeing something like a sympathomimetic response. Even the action of walking may cause a fatal ventricular dysrhythmia. So use a stretcher to move the patient or a stair chair, oxygen, and transport. So another one you might see, and it's kind of an interesting one here for you guys, I don't know if you've ever heard it before, let me know if you have, is nutmeg. You ever heard of the nutmeg as a inhalant?
Is that something from like TikTok?
It's not.
Yeah.
So nutmeg is a natural hallucinogen. Interesting, right?
Yeah.
Yeah. So people can snort nutmeg to start hallucinating, get high. Natural hallucinogens that are out there. Another one is Mucinex, but Mucinex DM. So the DM part of the Mucinex can cause people to get high as well. And that was going around for a while, especially in schools a couple of years ago. We were seeing people OD on Mucinex. I'm like, why are you guys ODing on Mucinex? And one of the girls said, because we get high off of it. I'm like, huh, interesting. Never would have thought that. But they overdose on Mucinex DM, they actually get a buzz, and they actually start getting high. So again, some things to think about.
I know years ago, Robitussin was a big one too, where they would robo-trip.
Absolutely, yes. Yeah, you're bringing back some stuff from years ago now. Yeah, Robitussin was a big one as well. That's why they don't give it out as much anymore. So yeah, there's a lot of other ones that are out there that we don't even talk about, that if there's a way someone can get high, they're going to find out and make it happen. So hydrogen sulfide, a highly toxic, colorless, and flammable gas with a distinctive rotten egg odor. If you smell it, we need to get out. Poisoning usually occurs by inhalation. Hydrogen sulfide affects all the organs, but it has the most impact on the lungs and central nervous system. They use this for suicide attempts, for committing suicide. So if you suspect that or presence of a toxic gas, you can't go in to save this patient. You have to wait for hazmat to show up, because you're going to end up dying as well. Some signs and symptoms also would be nausea, vomiting, confusion, dyspnea, and loss of consciousness. Seizures, shock, coma, and cardiopulmonary arrest. So as you can see, seizure, coma, death. That's what's happening here. So once the patient has been decontaminated, management is largely supportive care at this point. There's nothing we're going to be able to do for this patient in the field. We're going to monitor and assist patient respiratory and cardiovascular functions and get them to the hospital rapidly. So as you can see, some CMS sympathomimetics, which would be your CNS stimulants that mimic the effects of the sympathetic nervous system. That's why they call it sympathomimetic, as it mimics the system. So there's something called ATOM, which is 3 to 4, I'm not even going to pronounce it, MDMA. There's a lot of letters there. I want to, let's see, PCP, amphetamines, cocaine, crank, which is crack cocaine, heroin, amphetamines, methamphetamines, Dom, ecstasy, Eve, golden eagles, another one, ice, MDA, meth, molly, speed, uppers, all different things you might see. Again, all have the same effect for the most part when trying to see what you're going to see for a patient as far as signs and symptoms go. So a stimulant is an agent that produces an excited state. So frequently cause hypertension, tachycardia, and dilated pupils. This includes your pentramine hydrochloride, methamphetamines, amphetamines, and benzedrine. So these are designer drugs as well that are out there, such as MDMA, which are also frequently used and commonly taken by mouth, also injected by drug users as well. Cocaine may be taken in a number of different ways as well. So absorbed through the mucous membranes, across the skin. Immediate effects include excitement, euphoria, and also last less than an hour. But you can also smoke. Crack is also the most potent one that's out there by smoking it, getting it into your lungs. Other acute overdose is also a genuine emergency. So patients that have a high risk of seizures, cardiac dysrhythmias, and stroke with these, patients must also experience paranoia and hallucinations. These patients should not be left unattended at all and provide prompt transport. You just don't know what's going to happen. These patients require ALS intervention, cardiac monitoring as well. This one here was pretty big. I have not seen this as much since my days of working in 911 in Somersworth, which is probably 2015 or so, 2014. But bath salts used to be pretty big. Again, I have not seen them as much as I used to. I don't know if you guys have seen it more. I just know that I haven't seen it used much. It's kind of like gone away. The only treatment for this in the field that worked really well was a benzodiazepine, so Versed. Ativan didn't even work. It was Versed was like the key medication for bath salt overdose when they were going completely insane. So the catechins produce euphoria, which increase mental clarity and sexual arousal. It's very interesting to see someone on bath salts and the things that they do. Most users of this drug snort the powder nasally, and the effects reportedly last as long as 48 hours. The side effects to this stuff is unbelievable. They're absolutely insane. Has anybody seen a patient on bath salts before? You guys seen any of this?
No.
Unreal.
No.
Absolutely unreal. The last one that I had, the patient got naked at least 15 times in her house while we were there, and did a lot of inappropriate things and started attacking firefighters and cops. I see Kelsey's, it's bad in Bangor. Yep. So again, this stuff is, I mean, these people are even hard to take down. They're just, it's like a bunch of rage. It's insane. They need to be chemically taken down for this. So the adverse effects include teeth grinding, appetite loss, muscle twitching, lip smacking, confusion, gastrointestinal conditions, paranoia, headache, elevated heart rate, and hallucinations. Again, these patients were hallucinating like crazy. Again, they need chemical restraint, which I just mentioned before in the last slide. And the chemical restraint for bath salts is Versed. That is like the medication to be using. But now that ketamine is out, ketamine actually works a lot better as well. All right, marijuana, obviously, it says abused throughout the world, but most states now have made it legal. So nearly half of the Americans have tried marijuana. THC is the chemical in the marijuana that plant that produces its high. So it produces euphoria, relaxation, and drowsiness. It impairs short-term memory and the capacity to do complex thinking, and could progress to depression or confusion. So dealing with patients that smoke pot has not been that bad. Usually they're probably the best patients you're going to deal with. So I have not seen that, Kelsey, what you just put up there on the chat box. Kind of interesting, but wouldn't surprise me one bit, though. So obviously, with very high doses, patients may experience hallucinations and become very anxious or paranoid. So reassure the patient for transport with a minimum amount of excitement, and it's usually used marijuana is often used as a vehicle to get other drugs into the body. So again, I was saying before, marijuana, probably some of the better patients I've dealt with that are high. The question is, what do they lace it with? As they mentioned in the very last part here, a vehicle to get other drugs into the body. That's what we need to know. Okay, yeah, you smoked pot. What else was in it? That's what we need to know. So several states have legalized the recreational use of marijuana, and others have also allowed for medical use and products that contain THC. So edibles, obviously infused with marijuana. I've gone to a lot of these accidental ones where they were found in like fridges and whatever, and people ate them and go, oh God, I don't feel so well. So ingestion of marijuana can also lead to cannabinoid hyperemesis syndrome, hyperemesis syndrome as well. So we might see a lot of vomiting. If they're continuously vomiting and not stopping, then a lot of times a paramedic would be the best choice. They have medications like called metoclopramide or Reglan that can actually help with that. Synthetic marijuana or spice refers to a variety of herbal incense or smoking blends that resemble THC and produce a similar high. So I have not seen much of this lately. It was pretty big quite a few years ago, but not as much as I've seen now. Or if they are doing it, again, they're doing it controlled where they're not calling for EMS. Powerful and unpredictable effects may result in range from simple euphoria to complete loss of consciousness. Right, so hallucinogens. Obviously, hallucinogens alter the person's sensory perceptions. The classic example is LSD or acid. This was going around Wolfboro for a while, especially in the Brewster Academy area, where I was getting an acid or LSD call at least twice a week with this. Patients that are on LSD or acid, when you get to the scene, turn off your strobe lights. They did mention the commonly abused hallucinogen nutmeg is actually on there. So that's interesting they brought it up. So again, turn off your strobe lights or any kind of flashing lights, as it can agitate the patient or potentially cause them to have a seizure as well. But these are some of the names of the commonly abused hallucinogens that are out there. But it seems like acid and LSD is making a comeback. These agents can cause visual hallucinations, intensify vision and hearing, and generally separate the user from reality. And patients can experience a bad trip and have hypertension, tachycardia, anxiety, and paranoia. Those are the ones that are dangerous because they can come after you and think they're actually being paranoid and actually start attacking you. So you got to kind of prepare yourself, make sure the scene is safe. You may have to do physical restraints on these patients as well if they're starting to hallucinate. So again, you may have to protect yourselves in the back of the ambulance. So when they are on hallucinogens, we want to use a calm, professional manner and provide emotional support. So be there for them, talk with them, try to keep them calm, because once they start thinking that something's up, they start becoming paranoid. That's when they start losing it. It says do not use restraints unless you are the patient or is in danger of injury. Yeah, again, if the patient's in danger or you're in danger, restraints need to happen. We're not going to leave them unattended. We're going to watch because they're unpredictable at this point. And ALS assistance when appropriate. So again, if they need an airway, you can call for ALS. If they're at the point where things are unsafe, the scene is not safe, then we need to go to ALS intervention for chemical sedation or a chemical restraint. Anticholinergic agents, or anticholinergic syndrome, they call it. These medications have properties that block parasympathetic nerve. So you start getting the hot as a hare, blind as a bat, dry as a bone, red as a beet, mad as a hatter. And the last one would be seizing like a squirrel, which is not listed on there. So common drugs would be like Jimson weed, amitriptyline, or Benadryl. So if you see a patient that's hot, blind, and dry and red and acting crazy, probably an anticholinergic. So the other one would be like a tricyclic antidepressant. We don't see tricyclic antidepressants used as much. Now they have MAOIs and SSRI medications that are utilizing a lot more than tricyclic, but they are out there. Death from these agents can be very rapid. These require ALS backup right away. So they need a medication called sodium bicarbonate to help fix this patient if they're on a tricyclic overdose. These patients go from normal to seizure and death within 30 minutes. So seizures and dysrhythmias are best treated in the hospital. Again, we want to prevent that from happening, so sodium bicarbonate from ALS from a paramedic is something that's desperately needed for these patients if they overdose on them. Your cholinergic agents, obviously these agents overstimulate the normal body functions. that are controlled by the parasympathetic nerves. So this includes your nerve gases, which are designed for chemical warfare, and organophosphate insecticides. Well, we live in farm country, so organophosphates are definitely out there. And there's two medications that are utilized for this kind of stuff, and it's called Tupam and then atropine, are two medications, so otherwise known as a duodote, which is done with an auto-injector. New Hampshire and Maine used to carry them on their ambulance, but they weren't used for patient care. It was used for the provider. So if you came in contact with a nerve gas or organophosphate insecticides on a call, you could stick yourself in the thigh with this auto-injector, kind of like an EpiPen, to help reverse the effects. So poisoning results in excessive salivation, mucus, oversecretion, runny nose, urination, diarrhea, tearing of the eyes, and abnormal heart rates. So when we look at the cholinergic stuff, using two different methods. One can be dumbbells, which is diarrhea, urination, meiosis, such as pinpoint pupils, bradycardia, bronchospasm, bronchorrhea, emesis, lacrimation, which is excessive tearing, and seizures, salivation, or sweating. The other one you can utilize is sludgem. So it would be your salivation, lacrimation, urination, defecation, gastric upset, emesis, and meiosis or muscle twitching. So these are important for us to pick up on. Again, there's nothing that we can do as an EMT in the field for this other than transport the patient. And if a paramedic gets on board, we do not carry Tupam in the ambulance, but we do carry atropine, and we can start giving atropine to help this patient keep their heart rates up, because along with organophosphate and poisoning, you're also going to see a lot of bradycardia as well. So the most important consideration to avoid it is to avoid exposure yourself. So decontamination may take priority over immediate transport. Again, we have to clean these patients first. The hazmat team will take care of that part of it, and after decontamination, we're going to decrease the secretions in the mouth and trachea and provide airway support. Because remember, excessive drooling happens with these patients. So we have to make sure we keep the airway clean. So the duodote auto-injector may be available. Again, we do not carry those anymore. So the pyrrolidoxamine, that's your Tupam, and then atropine is the other medication that's in it. If a known exposure to a nerve agent with manifestations of signs and symptoms has occurred, use the antidote kit on yourself. Remember, it's not for the patient, it's for you. All right, so miscellaneous drugs, obviously accidental or intentional overdose with cardiac medications has become common with children and older patients, where they think they took their medications, but oops, no, they forgot, they took it again. So you may see like beta blocker overdose and things like that. We have patients that have extremely low heart rates. Again, if you have someone who's overdosed on their beta blockers, their heart rate's in the 30s, call for paramedic intercept for those, because they're going to give glucagon intravenous for that as a reversal for the beta blocker overdose. Some other miscellaneous drugs or signs and symptoms depend on basically the medication ingested. So again, you will not know until you find out by looking at the bottles, the medications, the chemicals, whatever it may be, using safety data sheets and contacting poison control, because they're going to be your key for any kind of treatment for that. Aspirin poisoning remains a potentially lethal condition. Ingested too many aspirin result in nausea, vomiting, hyperventilation, and ringing of the ears as well. And again, I'm going to go over that sheet that I gave you guys also. Patients with this problem have anxiety, confusion, tachypnea, so that's rapid breathing, hyperthermia, so obviously elevated temperature, and then a danger of having seizures as well. So overdosing with acetaminophen is also very common. And I'm drawing a blank of the name of the antidote for that. I can't think of what it's called. But it's given over a 3-dose series in the ER. ER, and then obviously up in the ICU. Overdose, unintentional or intentional, must be treated promptly and aggressively. Some alcohols, including methyl alcohol and ethylene glycol, are even more toxic than ethyl alcohol or drinking alcohol. So again, ethylene glycol you'll see in their antifreeze will cause severe tachypnea, blindness, renal failure, acute renal failure, and eventually death. So basically, you'll go blind, you'll have rapid respirations, and your kidneys will shut down. For food poisoning, obviously, always caused by eating food contaminated with bacteria. So there's 2 different types. Organism itself may cause disease. Organisms may produce toxins that cause a disease. So again, proper sanitation when cooking is key. And there's a lot behind all this, especially in the food service itself. One being prep areas. So vegetables and things like that need to be separated from meats. There's certain ways things have to be stacked in a refrigerator to protect any kind of cross-contamination. There's a lot of stuff that has to happen with all this to be done the appropriate way. And if there's any kind of cross-contamination, that's where food poisoning starts kicking in. These are all common causes of food poisoning, as you can see here. All a bunch of different ones that are out there. So one organism that produces direct effects of food poisoning is the Salmonella bacterium. When we get Salmonella, usually from raw chicken. So if you're cooking chicken and you're cutting it on a cutting board and you start cutting other vegetables and the things go together, then you have cross-contamination. And another big thing that we see also is you have your cutting boards and your prep for raw meats, and then you have your finished product, and they're kind of cross-contamination from taking raw, putting it on to something that's not. So other causes, obviously, character for Salmonella is characterized by severe GI symptoms within 72 hours of ingestion, including nausea, vomiting, abdominal pain, and diarrhea. So obviously, proper cooking kills bacteria, and proper cleanliness of the kitchen prevents contamination of uncooked foods. So very important to make sure things are kept clean. The more common causes of food poisoning is the ingestion of powerful toxins produced by bacteria, often in leftovers. So bacteria, the Staphylococcus bacterium, is quick to grow and produce toxins in the food itself. So foods left unrefrigerated is a common vehicle for that. Things need to be kept at certain temperatures, whether it be the cook temperature versus the storing temperatures as well. And if things get up to a certain area, it's something that they call a danger zone, where the Staphylococcus bacterium can actually start producing. So symptoms usually start within 2 to 3 hours or as long as 8 to 12 hours after ingestion when you get this. The most severe form of toxic ingestion is botulism. It can result by eating improperly canned foods. That's why we got to be careful when we start seeing dented cans and things like that. Symptoms are neurologic in nature, causing blurring of the vision, weakness, and difficulty in speaking and breathing. So again, all signs and symptoms look like a stroke. But really, it's an ingestion from botulism. Do not try to determine the specific cause of the acute GI problems. Gather as much information as you can. Transport the patient to the hospital. And obviously, when 2 or more persons are of the same illness, take along the suspected food so they can test for it. That's a good point, Kelsey, to mention. This is why you don't eat leftovers. Unless you've done, well, again, it's proper storage, but the thing is you don't know if it's properly done or not. So it can become very dangerous. So there are tens of thousands of cases of plant poisoning that are annual. Many household plants are poisonous if ingested, as you can see all here. A lot of toxic plants that are out there. So it is impossible to memorize every plant or poison let alone their effects. Again, medical control is the best way to get a hold of this. Not medical control, let me rephrase that. Poison control is what I meant to say. So obviously, take the plant to the emergency department. They're going to have to find out what it is, and they're going to have to find out a treatment for it. Again, I couldn't even tell you all the plants that are out there and treatments for them. So again, notify poison control of what you have, airway, vital signs, and provide prompt transport. As you can see here are some different plants that are out there as well. So irritation of the skin or mucous membranes is definitely a problem with the common houseplant called Defensia bat. I'm going to try to pronounce it. If anybody else can, let me know. So maintain an open airway, give oxygen, and transport the patient promptly to the hospital for respiratory support. So again, if you see kind of plant poisonings, you got to watch out for those. All right, so in review, to finish this up tonight, which of the following questions is of least pertinence to the EMT to ask a patient who intentionally overdosed on a medication?
What happens
D.
to people?
D.
Nothing.
D, correct. All right, number 2. A 30-year-old male who ingested an unknown substance begins to vomit. You should do what?
D.
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 The answer is A. We go back. So we want to collect the vomit and bring it with us to the hospital. Because again, they're going to send it to the lab for testing to find out what's actually in it. So we don't know what it is. Because the vomit, let's collect. I'm not saying collect the whole bag full, but good enough so they can get a sample at the hospital. Usually enough to put in like a specimen cup. Number 3, when caring for a patient with a surface contact poisoning, it is important to remember what?
Didn't even get out. Plunk up. D.
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 The answer is B. All right, let's go to number 4. The most poisonings occur via which routes?
D.
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 Oh, sorry. Actually, I want to go with C.
All right, the answer is B.
Oh.
80% is occurred by ingestion. You got to remember the elderly patients overdosing to kids taking pills that look like candy. So, how much activated charcoal should you administer a 55-pound child who swallowed a bottle of aspirin? Remember that the dose is 1 gram per kilo. If they're 55 pounds, divide by 2 and take off 10%. So half 55 would be
D.
B.
all right. Answer is B, 25. After taking Vicodin for 2 years for chronic pain, a 40-year-old woman finds that her usual dosage is no longer effective.
D.
What does the doctor request? A higher dose. This is an example of
B.
D.
B.
let's go with C. They built up a tolerance to that medication, so they need to go to a higher dose. Which of the following effects does drinking alcohol not produce?
D.
D.
D it is. Number 8, a 21-year-old male was found unconscious in an alley. Your initial assessment reveals that his respirations are slow and shallow, and his pulse is slow and weak. Further assessment reveals that his pupils are bilaterally constricted. His presentation is most consistent with an overdose of what? Pinpoint pupils.
B.
A lot of B's, and B it is, opiates. The mnemonic dumbbells can be used to recall the signs and symptoms of a cholinergic drug poisoning. The E in dumbbells stands for
Oh. I have no idea.
A.
I'm gonna go with C.
B.
Let's go with A. Emesis. So excessive vomiting. Number 10, food poisoning is almost always caused by eating food that contains
C.
C.
B it is, bacteria. So let me just bring up the that PDF that I wanted to show you guys. Where did it go? All right. Everybody see that okay? So-
So.
What was that?
Yes.
It's okay.
All right. So I sent this to you guys in a PDF in your email also. All right. So I kind of put it, so a couple things on there like tricyclic antidepressants. Remember the SALT acronym? So you'll see shock, altered mental status. The rest of it, though, you guys won't be able to tell unless you put them on an EKG. So there are some things that are kind of important there to pick up on. 3 things to look for in any kind of toxicology. Remember, vital signs, skin, and pupils. So 3 things to look for. Identify the pill. Is it rapid or extended release? And remember, you always get a bedside glucose as well. This is the cholinergic. So we talked about bradycardia, constricted pupils, looking at sludge or dumbbells, sludge them. Anticholinergic syndrome. I call it the Alice in Wonderland theme. Hot as a hair, dry as a bone, red as a beet, mad as a hatter, blind as a bat, and seizing like a squirrel. Look at your opiates, your tricyclics, your sedatives. Antifreeze overdose, obviously hypotension, hypocalcemia, renal failure. Here's an interesting one for you guys, though, too, is Bengay. So 1 tablespoon is equivalent to 23 tablets of aspirin. So think about this when kids start ingesting this kind of stuff. So they eat 1 teaspoon of Bengay is equivalent to 23 tablets. All right, so important to pick up. And the other one is Vicks Vapor Rub, which has camphor in it, which is toxic at 50 to 150 milligrams per kilogram. And there is 500 milligrams in 1 tablespoon. So I kind of threw these kind of things together. You can take these, you can cut these things out, make little cards for them in your wallets if you want to do that. It definitely helps out. So I just wanted to show you guys the toxicology handout that I did make for you guys to utilize. So the quiz will be ready for you guys at 10 o'clock to start taking. Other than that, there's no class this weekend. The next class will be next Wednesday. And then the following Sunday, we do have our in-person class again. Okay?
Yep.
I'm going to turn off the recording. We don't need to record all this.